Assistant Professor in the Department of Psychiatry at AIIMS Raebareli. It gives me a great pleasure to extend a warm welcome to all of you in this CME and workshop on rTMS, that is repetitive transcranial magnetic stimulation, which is being organized in collaboration with Global Psychiatric Association. We are truly honored by the presence of STEM faculties, distinguished guests, respective administrative officials, senior colleagues, young psychiatrists, non-psychiatrist healthcare workers, and all enthusiastic learners who have joined us both online and in person. Today's academic event marks another step in our ongoing efforts to enhance clinical knowledge and practical competence in the field of psychiatry. rTMS is emerging as a non-invasive, evidence-based neuromodulation technique. Through this hybrid mode of delivery, we aim to engage a wider audience and promote dissemination of expert knowledge. At AIIMS Raebareli, we are deeply committed to improving mental health care through education, research, meaningful collaborations. We are sincerely grateful to the Global Psychiatry Association for their support in making this event possible. I take this opportunity to thank administration and senior faculty members at AIIMS Raebareli and our distinguished speakers for making this event possible. A heartfelt thank to all participants joining us from various institutes and regions. Let this event serve as a platform for knowledge exchange, skill building, and clinical excellence. Once again, I extend my warm welcome to all. As we are about to start the program, kindly allow me to brief the sequence of events for today's academic program. We will begin with the introduction to the Global Psychiatry Association by Professor Reiner Heun, who has played a pivotal role in making this collaboration possible. At 10:30 a.m., Dr. Shruti will speak on neuroanatomical and neurophysiological basis of TMS. At 11 a.m., Dr. Anurag Varma will discuss the applications of rTMS in clinical practice. Following that, Professor Sujit will guide us through the understanding of parameters and protocol of rTMS. At 12 noon, Professor Mona Srivastav will present the recent advances of rTMS and offering valuable insights into innovations and future directions. At 12:30, we will conclude the morning academic session with formal vote of thanks, followed by felicitation of our esteemed guest faculty. This will mark the end of CME for our online participants. Post-lunch, the much anticipated hands-on workshop will begin at 2 p.m. and will conclude at 4 p.m. I would like to highlight to the online participants that they can post their questions and comments in the chat box. We will take the questions as the time permits after the session. Now, without any further delay, let us begin with the introduction to Global Psychiatry Association by Professor Reiner Heun.
Yeah, thanks for this nice introduction. My name is Heun, I'm a consultant psychiatrist, and we founded the Global Psychiatric Association with the hope to support people from all over the world to have available and easily accessible research and clinical practice training. So we provide a website, we provide and support educational events such as this, and we provide a YouTube channel which allows to show events such as this. So what I would like to say today that we will monitor and record as well as display the talks we hear today to a wider audience, and I hope that this will be well used. The idea of having a Global Psychiatric Association is that we saw the need to collaborate together with other people, but to do this not on a very organized and bureaucratic way, but do it on a one-to-one or one-to-several people way. So I found it very important that people from all over the world can collaborate, and I would like that to let you know that the Global Psychiatric Association is a platform. We don't charge anything, and we hope that people who haven't gone through the ranks are also able to contribute. So with this in mind, I wish you well, and I look forward for this very exciting and interesting event. And as I said, you can later watch the videos on the YouTube channel Global Psychiatry Archives. Thanks for your interest.
Thank you, sir, for introducing us to the vision and scope of Global Psychiatric Association and its academic activities. Now, I would like to request all the participants to quickly fill up the pre-test form we have prepared, so that so there will be two tests, one pre-session and one after all the sessions are over. So participant can scan this QR code and fill the questions quickly, so that we can proceed to the next session. So sending the link to this form in the chat box for the online participants, so that who are not able to scan right now, they can do it. So moving forward, our session will be started by presentation by Dr. Shruti Sinha, who will speak on neuroanatomical and neurophysiological basis of TMS. The session will be chaired by Dr. Anurag Varma. Let me introduce Dr. Anurag Varma. He has done his MBBS from Armed Forces of Medical College, Pune, MD DPM from Grant Medical College, Mumbai. He's currently working as consultant psychiatrist in Amelin Medical College, Prayagraj, UP. He has done various courses, including the course, scientific course on Rogerian supportive psychotherapy, CBT, child and adolescent psychiatry. He's fellow of Indian Psychiatric Society, ICAM, life member of IPS and various other international and national societies. He is currently course coordinator in child psychiatry, ICAM. He has been past editor of AMA, vice president of IMA, AMS Allahabad. His area of interest includes sports psychology, depressive illness, and de-addiction. He has various publications in psychiatric and medical journals, both national and international. And he is actively involved in teaching of postgraduates in the Department of Medicine and Psychiatry. So I would like to invite Dr. Anurag Varma to please introduce our speaker and start the session.
Morning, everyone. It's a pleasure coming here. Let me introduce Dr. Shruti Sinha. Before she was here, we had the privilege of having her as an SR in our department in Prayagraj. She was one of the best academicians I remember, and very hardworking with the patients. So Dr. Shruti is MD Psychiatry from King George's Medical University, Lucknow. She is an MBBS also from King George Medical University, Lucknow. And now she's an assistant professor and heading the department in AIIMS since October 2023. Her areas of interest is neuromodulation, consultation licensed psychiatry, and psychiatry in extremes of age. Welcome, Dr. Shruti.
Good morning and a warm welcome to all our participants online as well as offline. I'm here to brief you about the neuroanatomical and neurophysiological basis of TMS, which will form a base so that you can understand the other concepts which will be delivered by our senior speakers. The learning objectives of my presentation would be to understand the basic principles of how rTMS works, to learn the key neuroanatomical targets of rTMS in psychiatry, to understand the neurophysiological mechanisms underlying the therapeutic effects. And we'll lay down a structure so that we can understand the clinical implications and rationale for target selection. So TMS is a non-invasive brain stimulation technique which uses electromagnetic induction. Excuse me, are my slides visible to the online participants?
They're not. It's not your slides. It's your CV. But you could move forward, possibly.
So I hope my slides are visible now.
Yes.
Thank you, sir. So TMS is a non-invasive brain stimulation technique. It uses electromagnetic induction to modulate cortical activity. What is a common misconception is that it is the magnetic currents or magnetic stimulation of the brain. But actually what happens is that the magnetic field, the changing magnetic field induces currents inside the brain cortex. So the brain cortex, being a conductor of electricity, it acts as base where the induced currents can move, and thereby bringing about the changes which help in therapy purposes. This developed in the 1980s and now is widely used in research and clinical settings. TMS basically runs on the Faraday's laws of induction, which says that a rapidly changing magnetic field induces the electric currents. I think the brief video here is self-explanatory, that how a changing magnetic field generated by the coil in our machine induces currents which then modulate neuronal excitability. So now that we know that it is what TMS is and how the electric currents are produced, we move on to what are the types of TMS. So what is most commonly used is single pulse and repetitive magnetic stimulation. Single pulse is more of diagnostic value, and rTMS, repetitive pulses, have therapeutic effects. Going on to the actual types of TMS, like I said, single pulse TMS measures cortical excitability. We can use paired pulse TMS to evaluate intracortical inhibition or facilitation. rTMS, which is the main topic of our presentation, and CME, this is the modulation of the long-term modulation of the cortical function. And theta burst stimulation is the newer variant of the way of stimulation in which short bursts are produced. And it is said that it is more in alignment with the actual cortical activity of our brain. So this is the most recent technique, and it helps us deliver TMS therapy more rapidly in more number of patients within a short period of time. So now moving on to the neuroanatomical targets of rTMS. We have to understand that since the magnetic field which we are generating through the coils, they exponentially reduce in their intensity from the distance, in parallel with the distance from the coil. So what we can access through the effects that we can produce is only on the superficial cortical structures of the brain. So these are the major areas which we target: primary motor cortex, the dorsolateral prefrontal cortex, and the occipital cortex in certain cases. Also, there is secondary modulation of the connected subcortical areas via networks. So we have to understand that though the magnetic field cannot reach the deeper parts of the brain, but through these subcortical connections that we can see from the figures, we can modulate changes in the deeper structures as well. Plus, now with developing technology, there are other kinds of coils which help to access the deeper structure also, which we'll discuss later. So like I said, dorsolateral prefrontal cortex is the key target area. The left DLPFC is the one which we use in major depressive disorder, and it is the target of what we call high frequency rTMS. The right DLPFC is sometimes the target for low frequency rTMS for anxiety disorders or depression. Now, other experimental and alternate targets are being used and in research. We are using the medial prefrontal cortex in PTSD or OCD, the anterior cingulate cortex in mood regulation. After DLPFC, the supplementary motor area is also being in use, and inferior frontal gyrus. These are areas of research right now. These will be discussed in more detail by the other speakers. Now, coming on to the anatomical landmarks, how do we locate the area to be stimulated? So like in our surface landmarks that we do in our UG studies, so we have certain areas and we use the location of the approximate location of that area through an area which we can directly check. So the motor area is something which we can stimulate and directly observe the changes in the form of movements in the fingers or the thumb. And using this motor area, we use a 5 to 6 centimeter area anterior to the motor cortex along the parasagittal line. This is the most common way of targeting the DLPFC, which is the most common target of our therapeutic interventions. Apart from that, with research and with more developments, we even use neuronavigation for precise targeting of the brain areas. This shall be discussed by our other speakers. We have to understand the functional neuroanatomy to know the basis of therapeutic treatments. So motor cortex is the area which we use to see motor evoked potentials, which can be directly observed. So this is mostly used for locating the other areas where we want to target rTMS. The prefrontal cortex is the area which is most often used for therapeutic purposes. We should know that this is the area which governs the executive functions and mood regulations. So that is why it is the most important target for our interventions. The parietal cortex also involved in attention and spatial awareness. There are other areas which are being researched and which are being used for therapy, especially for things like persistent auditory hallucinations in cases of schizophrenia. Coming on to the neurophysiological mechanisms, it is a depolarization of the neurons via the induced currents, which is the primary mechanism. Also, it is proposed that there is synaptic plasticity, which is there in our cortical structures, which helps in the long-term changes in the brain which happens. So this is mediated by long-term potentiation or long-term depression of the cortical areas. And for this, we use high frequency and low frequency of TMS. Also, it is postulated there is a modulation of GABAergic and glutaminergic activity in the brain. And the network level effects, like I said, that there are other effects which happen in the deeper structures through the networks that we had discussed previously. So those network level effects are mediated via cortico-cortical and cortico-subcortical connections. This is how usually coils are placed, and this is the setup of giving stimulation. We can observe that just the placement of coil can also affect how much activity is received in the brain and precisely which area receives the stimulation. Now coming on to the mechanism of action in detail, like we said, electromagnetic stimulation, a rapidly changing magnetic field produces electric current and causes the depolarization of the neurons, and the direct cortical effects and downstream network modulation is affected thereafter. We had discussed briefly the frequency dependent effects. The high frequency of rTMS produces an excitatory effect, and the low frequency causes an inhibitory effect. So as per the desired effect that we target, we can use different frequencies. And like I mentioned, theta burst stimulation, this mimics the natural brain rhythms. And we use intermittent TBS for excitatory and continuous TBS for inhibitory responses. Further neuroplasticity, like I said, there is a modification of the synaptic strength in the local and remote areas. And this is mediated via the cortico-cortical and cortico-subcortical structures and circuits. The network effects overall, rTMS modulates that a default mode network, salience network, and cognitive control network. So these are actually what is happening inside the brain. And the functional connectivity changes, we can now measure them using fMRI and EEG studies along with rTMS. So we have facilities of using rTMS along with fMRI or other imaging techniques so that we can monitor these changes and monitor whether we are reaching the exact target area or not. Now, how to measure TMS effects? The motor evoked potentials are what are generated from the stimulation of the motor cortex. So like you can see in the figure, the TMS coil is where due to the flowing of electric current, a magnetic field is generated, and it is usually perpendicular to the coil. The maximum activity, the maximum field that is generated is at the center point of the coil, and we try to maintain as much proximity to the area targeted through the central position. Like I said, as we move away from the coil, the field exponentially decreases. So to gain a maximum effect, we have to maintain as proximal placement of the cortical structure to the coil as possible. We can also have EEG coupling to view whether we are reaching the precise location or not. And like I said, TMS, fMRIs can also be used for network effects. Also, we can ultimately see the behavioral outputs with our cognitive and clinical task performances. So we can see in this figure, when the superficial cortical regions are stimulated through the descending pathways and through the corticospinal tract, they reach the motor neurons, and thereafter stimulus is produced, which can be seen in the form of motor evoked potential on our EMG and other devices. So this would be dealt with my following speakers, the areas where TMS is used. This figure briefly shows us that what superficial structures we can access through TMS, and they can be used in different therapy and different indications. So briefly, I'd like to mention that this is mostly studied in depression, and it is FDA approved for the same. And mostly we target the left DLPFC, and like I mentioned before, the right DLPFC is sometimes used for low frequency stimulation. This is also used in research for smoking cessation and other experimental areas like chronic pain and bipolar depression. Now, coming on to limitations and considerations of rTMS, there is a depth limitation. What we can reach is mostly 2 to 3 centimeters from the scalp, like I've already explained. Also, there is always a chance of variability in the individual anatomy. So when we use neuronavigation, we can be more precise about where we are actually reaching. So the 5 centimeter rule is a mere approximation that we use, but there may be individual variations. There are minor side effects like discomfort, headache. Rarely seizures may occur. So when we screen the patients, we have to make sure that they don't have an underlying seizure disorder. There are other screening criteria we'll discuss. Because of the stimulation, there is a direct stimulation of the temporal muscles, and that stimulation is the reason why patients often have discomfort and headache. So we usually, if it is mild, we gently reassure them, and mostly these effects go away with time. But if it is very bothersome, then we might have to abort the therapy. There is a very much importance of precise coil positioning. So an approximation and with individual variability, we might be actually missing out the real therapeutic areas. The other limitation, of course, are the cost, the availability, and of course, the lack of response in 30 to 40% of patients. I think with developing technology and with more widespread use of rTMS in institutes, the cost factor we might be able to overcome, especially in government institutes where we are able to provide this therapy at a very minimal cost to our patients. We have already discussed this. The common side effects are scalp discomfort and headache. Serious side effects are seizures, which we have to look for. The contraindications, the major contraindications of rTMS are metal implants at the head and a history of epilepsy. Future directions would be dealt by our other speakers. The figures briefly show what is deep rTMS. So these are the coils which are used for accessing the deeper structures of the brain. But the limitation of these coils are these are for individualized treatments. We cannot use the same coil for other kinds of treatment. So if we have a deep coil for OCD, we can use it only for OCD patients. Whereas the other coil that we use, the movable coil, we can place it in different areas and use it for different indications. I'll summarize that TMS modulates the cortical activity via magnetic induction, and it targets specific cortical and network regions. It works through both local excitability and widespread network effects. And this is an area which continues to evolve in both clinical and experimental domains. These are the take-home messages which I expect all of our participants would gain. This is a non-invasive neuromodulation technique. It is the neuroplastic changes that we are targeting. The most common target is the DLPFC, the left DLPFC for depression. And efficacy is linked to the modulation of broader brain networks. This is a promising tool with growing applications in psychiatry. You can go for further reading. There are books and videos available for understanding rTMS. I would end by my favorite quote, that if the human brain was so simple that we could understand it, we would be so simple that we couldn't. So it is definitely hard to understand the brain, but all these techniques are helping us to gain more and more access to our physiology, and therefore devise more treatments for our patients. Thank you for patient listening.
Uh, Thank you, Dr. Shruti Sinha, for that in-depth and comprehensive presentation on neuroanatomical and neurophysiological basis of rTMS. So the next talk will be delivered by Dr. Anurag Varma, who will elaborate on applications of rTMS in clinical practice. The session will be chaired by Professor Sujit Kar. Let me take a moment to introduce Professor Sujit Kar. Right. So, Sir has done MBBS in 2005 and MD Psychiatry. Then he's currently additional professor of psychiatry in King George Medical University at Lucknow. Right. His area of interest is particularly in brain stimulation. His number of publications and indexes are huge, which indicate his keen interest in research as well as clinics. He is member of various international and national psychiatric society. Currently, he is also editor-in-chief of Indian Journal of Health, Sexuality, Culture, Medical Research Bulletin, deputy editor in Indian Journal of Clinical Psychiatry, and Indian Journal of Behavioral Sciences, as well as his editorial board member of World Journal of Psychiatry, General Psychiatry, Brain Sciences, and also a treasurer in Neuromodulation Society of India. A significant contribution from him to the research in psychiatry puts him in top 2% of the world, according to various reports. So, without any further delay, I would invite Professor Sujitkar sir to please introduce the speaker and continue the session.
Good morning, everyone. It's a pleasure to invite Dr. Anurag Varma for the next presentation. Dr. Anurag Varma is a graduate from Armed Forces Medical College, Pune, and he did his MD. Subsequently, he is practicing as a consultant psychiatrist at MLN Medical College, Prayagraj, and he's a fellow of multiple psychiatric societies and is life member of several societies. He has course coordinator for child psychiatry ICAM and is vice president of Indian Medical Association Allahabad branch. His area of interest is sports psychology, depressive illness, and de-addiction. Sir is having several publications and attended various conferences. And now I invite sir to speak on his presentation, his application of TMS in clinical practice. Over to you, sir.
Thank you for the kind introduction. So first of all, there's a disclaimer. I'm not an expert in rTMS. We just got the rTMS machine. It's the same machine which you have in AIIMS, and we just got it 3 months back. So once this machine came to our medical college, I was talking to various psychiatrists in Prayagraj and amongst our colleagues, and they were asking me, okay, now that rTMS is there, so what can we do with rTMS? How can other psychiatrists, the clinical practitioners can gain from this field in the medical college? So I would be speaking more from a clinical perspective, from questions which arise from our colleagues, from psychiatrists who are in private practice also. And I would take this opportunity to learn from Dr. Sujit Kar and Professor Mona, who have more experience in rTMS besides Dr. Shruti. So with that, I'll start. So what are the reasons of increasing use of rTMS? We all have been having so many medicines in psychiatry. We are having so many techniques, counseling, but there is still a treatment gap. And rTMS is a very good non-invasive application that has come, and it has shown that it is more acceptable to the patients as compared to ECTs, which use has becoming decreasing nowadays because of the increased legal implications and the stigma which has been there from some times immemorial, and we haven't been able to deal with that. What are the benefits which we get from rTMS in our clinical practice? First of all, it addresses treatment resistance, offers hope for patients who are not responding to medications and psychotherapy. Very well-known example, and it's been mostly used in depression and OCD. It is non-invasive, well-tolerated. It has precision targeting, which Dr. Shruti just mentioned. We have MRI, we have functional MRI, in which we can actually target. Suppose a patient has had stroke, we can actually see the MRI and fMRI, and we can use and place our coils and plan our protocols accordingly to that. Dr. Shruti had already mentioned that it enhances neuroplasticity, especially in stroke, depression, chronic pain, and otherwise also. It has expanding application, just not in psychiatry, but most of the machines are now commonly there in the Department of Psychiatry and Neurology, and also rehabilitation. In fact, even in Prayagraj, our machine is jointly being used by both the Department of Neurology and Psychiatry. Again, it has minimum systemic effects, as we already mentioned, because we have precision targeting and it is a non-invasive method. So what are the indications? Have been already briefly mentioned. We had the first indication of the US FDA approval, which we got, was in 2008 for major depressive disorder. Then later on in migraine, for migraine 2013-14. Then obsessive compulsive disorder, it was approved in 2017-18. 2020, smoking cessations. Also emerging experimental indications for PTSD, also GAD, major depressive disorder with anxious overlay. Addiction has been shown to have good results, especially in smoking, also in other addictions like cocaine. Chronic pain syndrome is something which the neurology colleagues are also very, very excited about. And since we have mentioned about neuroplasticity and motor stimulation, so we also have a role of rTMS in stroke rehabilitation, besides auditory hallucinations and all in schizophrenia. The timeline, we've already spoken about this, of the FDA approval which we got for rTMS in various disorders and in certain disorders which has been used. There are certain screening questionnaires for rTMS which we have been broadly described. There are some contraindications for rTMS, and these are the patients which might not be able to take. Maybe absolute contraindication can be cochlear implant, because the problem happens is if you use an rTMS, that causes heating. This can lead to the implants or the metallic implants which are there in our brain to get heated up. It can cause certain side effects, but absolute contraindications are not there. There are indications where it can be safely used in pregnancy, also in child psychiatry. However, FDA approval is yet to come. In TMS, if it has been used in the past, or if an MRI has been done, it actually decreases our ease of use, or it helps us, because there are certain protocols which are common in MRI screening are also there in rTMS, which Professor Sujit is going to talk more in detail now. So as I said, I'll discuss more of the cases which we get and which we think rTMS would be a good treatment option. For example, this is one of the females patients we had in Prayagraj. She had major depressive disorders, many episodes. She's been having it for 9 years. We have been given a trial of escitalopram, and according to the STAR-D protocol and CADMAT guidelines, after adequate trial of SSRIs. We augmented the patients with mirtazapine. Not getting any response, we tried SNRIs. Desvenlafaxine was used. Again, no response. We started augmentation with aripiprazole. With aripiprazole, she developed a lot of akathisia, and she did not want to take it. Problems happened with sleep disturbances, poor appetite. She, at that time, also developed certain suicidal ideations. So we went for lithium augmentation, although there was no history of any bipolarity in the patients. But again, even with lithium, she did not show much response. She by the time also came to know about the online CBT which is available, and she contacted a psychotherapist, and she had sessions of CBT. Again, no improvement. She continuously used to talk about brain fogging and not able to work, loss of memory, and persistently having low mood, early morning awakening, psychomotor retardation, feeling a lot of fatigue, and suicidal ideations. Her Hamilton Depression Rating Scale was 24, and because she was from a middle-class family, she used to work partly as a teacher, and she could not continue her job, and she became dependent more on her family and in-laws, which was also one of the problems she presented with. So Dr. Sujit, like he just spoke about that rTMS is beneficial for usually first patients. But again, in this patients, we have rTMS, which can be a good treatment augmentation or another armamentarium in our course for managing these kind of patients. Suicidality also, rTMS has been shown to reduce suicidal ideations. For that, accelerated rTMS sometimes for acute suicidality. Not my experience so far, but this in future can also be one of our accelerated rTMS, which maybe Dr. Sujit Kar and Dr. Mona would elucidate further, could be one of the also beneficial effects of using accelerated rTMS, and certain times it has been seen. Another case we had, a 31-year-old female, she was suffering from severe OCD. Her duration of illness was 6 years. She had repeated checking rituals, obsessive doubts about blasphemy, and magical ideations. She also had comorbid generalized anxiety. What used to happen was, this was like something which was the patient, when she was referred to us, she had also visited the orthopedics department. Her magical belief was that she used to always keep her fist closed. And she started developing contractures because of that, because she used to think if she would open her fist, it would lead to something bad happening, or somebody might actually have an head injury, or her head might burst open. She also had, the place she was staying was, there was in her room and in between her kitchen, there used to be a lobby where there was a small mandir. And every time she used to go from her house, from her room to the kitchen, she used to cross that, and she used to close her eyes and not look towards that mandir. And because of that, she several times had a fall. She used to fall down. So all these problems she was having. We had given her an adequate trial of fluoxetine. We reached our target dose of 80 to 100 milligram. No response, although it caused a lot of side effects like severe GI upset, insomnia. Same thing happened with sertraline, intolerable nausea and GI side effects. Clomipramine was added. It was built up to 75 milligram, but even with that, she had a lot of sedation. And because she used to keep her fists closed, a little bit of work she used to do, she started developing tremors. And because of that, she refused to take all pharmacotherapy voluntarily. Once she came to us, her Vibox score was 28, which was in severe. And because of the daily distress and impairment in her work and social life and failed ERP trial, we decided to give her rTMS. The third case, as I said, the rTMS, like any other treatment protocol, it has been found more helpful in treatment naive patients, or if we put rTMS early in the treatment disorder. Now we have pretty well-read people. So this was a patient, software engineer. He had an obsessive doubts with compulsive checking. He had a pretty good insight into his history. He just had a girlfriend, and he had actually read about SSRIs and the sexual side effects which SSRIs cause, and he came and said that I'm not interested in taking SSRIs because they're going to cause a lot of sexual side effects, and I've read about rTMS, and I'm willing and I'm giving my consent. And please, doctor, now that I've read that it is there, so I would request rTMS, and my family and my girlfriend and all are more interested in this form of therapy. So this is like with more and more better read people, more aware people, we have more acceptance of rTMS. This is another case which was there in our neurology department. Around 60-year-old male, he had an ischemic stroke in the left MCA territory 10 months back. Because of that, he had hemiparesis, and with the hemiparesis, which was he was given treatment and exercise, and he started improving, gradual improvement of power, but full recovery did not happen. And the past 3 or 4 months, his improvement started decreasing. That plateau phase also led to onset of depression. His depressive symptoms were apathy, low mood, fatigue, withdrawal, and again, we included the motor deficits. And because of the protocol, he was hypertensive, diabetic, and prevention. So he already was on 12 or 13 medications from other specialities. And once we had started him on, again, escitalopram was started, but he had poor response to it. The patient, again, because of the amount of medications, he started becoming fatigued, demoralized, and often used to stop taking his medication. So along with our neurology colleagues, we have planned to give rTMS to this patient. So I'll conclude by saying that obviously we still have a lot of consensus recommendations highlighting the issues in rTMS and also the possible useful uses which we have. As more and more centers start using rTMS, we would have more data from India. And as more and more practitioners start using it, we would have real life indications and real life problems, and implementation of rTMS based on evidence-based recommendations, and also more and more data regarding its safety and efficacy. Obviously, it's something which we just started using, and we need additional research and to determine the optimal treatment parameters and algorithms for implementation of rTMS according not just in academic institutions, but also in general day-to-day life. Yeah. Thank you.
Thank you, Dr. Anurag Varma, sir, for excellent and insightful presentation, especially involving the clinical scenarios in which the audience can think of applying rTMS. Also, thanks to Professor Sujit, sir, for chairing the session. It was truly a treat for all of us who have gathered here to deepen our understanding of rTMS. Our next session will be conducted by Professor Sujit, who will speak on understanding of parameters and protocol of rTMS. This session will be chaired by Professor Reiner Heun, whom I have already introduced earlier. I would request just a minute, sir. So I will just briefly introduce Professor Reiner Heun, sir. He is a German psychiatrist and an academician, associate professor in psychiatry and psychotherapy at University of Bonn, editor-in-chief of Global Psychiatric Archives. He is known for his works in functional neuroimaging, genetic and epidemiological studies, as well as several clinical trials on various psychiatric disorders. He has received funding for research from various institutes, including German Research Foundation. He is recipient of multiple clinical excellence awards from NHS Trust. He has published in leading clinical journals in Nature Genetics and Archives of General Psychiatry. So I would now request Professor Heun to take over the session and introduce our speaker.
Right. Okay. Thanks for this invite and thanks for letting me support. I wouldn't want to repeat too much because Professor Carr, who is very well known, has already been introduced, and he's a very active researcher and in several organizations which have been mentioned in the previous talk. But I would like to add one thing, that he's a very kind and friendly person to work with. And the other thing is that he's a chair of the Global Psychiatric Association and is very active in organizing the conference. Last year, we had a very interesting conference of the Global Psychiatric Association, and Professor Carr is organizing this year's event as well, which will be in November. So, as he has just been introduced, I would like to say that I'm looking forward to his talk, and his talk is about the protocols and parameters of rTMS. Sujit, up to you.
Thank you so much, Professor Reiner. Thank you so much, organizers, for giving me this opportunity for this presentation. Yeah. I hope my slides are visible to all of you,
Not
particularly
yet.
for the online participants.
Not yet.
Is it visible now?
Yes.
Yeah. So I will be talking about approach to selection of patients for rTMS and setting protocols for evidence-based protocols for rTMS. My previous speakers, they already discussed about the neurobiological basis of the mechanism of action of rTMS and the clinical indications of rTMS. Now I'll be talking, my presentation will be a bit of overlap of these previous two presentations, but I got the opportunity to continue my presentation because we are running fast. So we have enough time to discuss about the practical parameters of rTMS. So thank you, Dr. Shruti, for giving me additional time for this presentation. Regarding selection of patients for rTMS, our selection basically depends upon who are those patients who are suitable for rTMS. When we are doing a suitability assessment, we need to refer to what are the indications, what are the contraindications of rTMS. And there are a set of indications and contraindications. Coming to the indications can be broadly divided into two types of indications. There are indications that are approved by the FDA and other agencies. And there are some indications that are not approved by FDA. We call them the off-label indications. So the FDA approved indications are already been discussed. The first indication for which rTMS got approval by the FDA was depression in 2008. Subsequently, multiple other psychiatric conditions like OCD, like smoking, different protocols of rTMS, like coming from conventional TMS to intermittent theta burst stimulation, deep TMS, they got approval by FDA. So when we are talking about approval of rTMS by FDA, what exactly it refers to? Not all the machines are approved by FDA, not all the coils are approved by FDA, not all the target areas are approved by FDA, and not all the protocols are approved by FDA. There are various protocols. So FDA gives approval to a particular machine, to a particular coil, to a particular target area, and to a particular protocol. So it is very specific. Suppose we use a particular coil of a particular machine, and that is being approved for depression, that you cannot generalize for other psychiatric illnesses. That coil may not be approved by FDA for OCD, may not be approved by FDA for smoking or other psychiatric conditions. So it is not a blanket approval. It is a very precise approval for a particular coil, for a particular machine, for a particular protocol, and for a particular target area. So we need to understand this. Now there are many regulatory clearances and approvals for therapeutic protocols of TMS in various psychiatric disorders. Some of the protocols are using conventional TMS, and some of the protocols are using the newer version of TMS, that is deep TMS and theta burst stimulation. My presentation will basically focus on more of a conventional TMS because of paucity of time. But to give you an overview about, for the condition major depressive disorder, the primary target area is left dorsolateral prefrontal cortex if you are using a stimulatory protocol. Stimulatory protocol, basically I refer to a protocol of high frequency protocol, or if you are using theta burst stimulation, then intermittent theta burst stimulation will be a stimulatory protocol. But you can target right dorsolateral prefrontal cortex as well, but that is not approved by FDA. If you are targeting right dorsolateral prefrontal cortex, then the protocol will be an inhibitory protocol. You can go for the low frequency rTMS, or you can go for the continuous theta burst stimulation. People have tried with bilateral dorsolateral prefrontal cortex, particularly when they are using the H1 coil, which is a deep TMS. It gives bilateral dorsolateral prefrontal cortex, particularly targeting the inferior frontal gyrus, insula part. They are also involved by this neuromodulation facility, that is deep TMS, H1 coil. When there is comorbid anxiety, depression with comorbid anxiety, then bilateral DLPFC may be useful, particularly people who are using deep TMS using the H1 coil, they can refer to that. Even you can target the left dorsolateral prefrontal cortex alone. That is a single cortical target. Coming to OCD, actually OCD causes involvement of the striatal structures. Striatum is deep seated, and the striatal connectivity to anterocingulate cortex and medial prefrontal cortex, they can be they are also deep seated, so they cannot be reached by the conventional rTMS coil. So H7 coil of deep TMS can give a penetrability to the deeper regions, particularly the anterocingulate cortex and medial prefrontal cortex. But if you are using conventional TMS, you can modulate the cortical activity of the functionally connected areas of the striatum, that is supplementary motor area and the pre-supplementary motor area. So that can be modulated. Even DLPFC is another target of OCD. I will be coming to the evidence in favor of the different areas when I will be talking about OCD in detail in subsequent slides. Smoking cessation is a recent approved condition that uses H4 coil, particularly it is bilateral inferior prefrontal gyrus, prefrontal cortex. It is being targeted by H4 coil by using deep TMS, and recently approved by FDA for smoking cessation treatment. Coming to the summary of recommendation, that FDA has approved the level of evidence for high frequency rTMS over left DLPFC is the level 1 evidence, the highest level of evidence. We have evidences of randomized controlled trials, double-blind randomized controlled trial, and the systematic reviews and meta-analysis on that. So that is the most highest level of evidence. We have evidence for that. When we are talking about low frequency rTMS targeting right dorsolateral prefrontal cortex, again, we have several double-blind randomized controlled trials. So level B evidence, which is also a very good evidence. When we are talking about unipolar depression, the level of evidence is the highest level of evidence, that is level A. When we are talking about PTSD is another indication where anxiety symptoms are very prominent and autonomic arousal are quite prominent. High frequency rTMS targeting right DLPFC can be one potential way to deal with PTSD. So the level of evidence is level C. It's more of randomized control trials or open level trials. They come in this category. If you are targeting auditory hallucination, particularly persistent auditory hallucination in schizophrenia, then the target area is left temporoparietal junction, that is T3P3 junction. So level of evidence is level C. If you are targeting the negative symptoms of schizophrenia, then high frequency rTMS targeting left DLPFC is the target. Level of evidence is level B. We have well conducted double-blind RCTs, several RCTs conducted in several regions of the globe. Addiction is another emerging area where possible effect of high frequency rTMS over left DLPFC in smoking and alcohol use disorder as well as in cocaine use disorder. So there are some emerging evidences. The level of evidence is level C. Now there are other psychiatric indications which are not approved by FDA or other competent agencies who deal with giving approval for devices for use in various neuropsychiatric conditions. One of the condition is neurocognitive disorder. Particularly, the evidences are more in favor of Alzheimer's disease and post-stroke cognitive decline. And there are some evidences the cognitive decline associated with Parkinson's disease. So these are the conditions where neuromodulation like TMS can be used, and the common target area being the left dorsolateral prefrontal cortex. People tried with high frequency rTMS ranging from 10 Hz frequency to 20 Hz frequency. Then cognitive symptoms of schizophrenia is another potential target of neuromodulation. They are again the same target area, left dorsolateral prefrontal cortex, using the high frequency rTMS. Eating disorder is not much studied area, much studied condition, but there are several studies that talk about the evidence of rTMS in eating disorder. There are some important target areas. I will be talking about those target areas when I will talk about eating disorder in detail. The common target area, people say that eating disorder is a phenomenon. There is a lot of cognitive errors associated with self-image, a lot of cognitive error associated with body shape, and usually patients with eating disorder, they have comorbid depression and anxiety symptoms. So the potential target area becomes the left dorsolateral prefrontal cortex. Another model of explanation for eating disorder, it's more of a compulsive ritualistic phenomenon of eating or purging. So this can be more of a in the spectrum of compulsive phenomenon, obsessive compulsive phenomenon. If that goes in that direction, then orbitofrontal cortex and the supplementary motor area can be another potential target area. So people have tried those areas. ADHD, autism are the commonly used, neurodevelopmental disorders that are been targeted in using rTMS. There are some preliminary evidences, though there is no FDA approval or approval by any competent agency to use it as a recommended modality of treatment. There are when to avoid rTMS. There are several contraindications. There are some common side effects that Dr. Shruti and Dr. Anurag has already discussed. That pain, headache, neck pain, these are the common side effects reported by patients with who are receiving TMS. Usually the symptoms are mild and self-limiting and does not require discontinuation of rTMS. Mostly self-assurance and more of some procedural adjustment and more of if the pain is not tolerable, a short course of analgesics can be enough in dealing with these issues. But sometimes, rarely, patient they report with some serious side effect like seizure, but the incidence is quite low, just like the risk of Epstein anomaly with lithium. It's quite rare. So similarly, risk of seizure with rTMS is very rare. So it's a very uncommon phenomenon, but we need to be prepared for that, particularly in those individuals who are having a history of seizure in the past, those who are taking some medications which are having some pro-convulsive effect like clozapine, like clomipramine or tricyclic antidepressants in a high dose, or those patients who are having receiving rTMS with a high frequency protocol. High frequency protocol is having a tendency to cause seizure-like activities in some of the patients, or those patients who are having a significant sleep impairment that can reduce the seizure threshold and increase the risk of seizure. In those individuals, you need to be very much cautious. There are some clear contraindications to rTMS, particularly those individuals who are having cochlear implants. Cochlear implants and those individuals who are having some metallic device, particularly ferromagnetic device, iron, copper or nickel containing device, at least within 10 centimeters from the target area. Because the classical, the penetrability maximum strength of magnetic field is around 2 to 3 centimeter from the point of maximum field of electric, from the center of the coil. But the magnetic field can extend up to 10 centimeter if there is a pacemaker in the neck, particularly somebody is receiving vagus nerve stimulation. If there is a cochlear implant, if there is a metallic thing in the around the neck, so that may influence. Suppose somebody is having a central vein catheter is given, and suppose somebody is undergoing for deep brain stimulation, an electrode is already placed over the scalp. So it may alter the pulse generation in that particular area. So it is better to avoid. These are contraindications for use of TMS. Particularly when you are talking about the pediatric age group, majority of the studies, they excluded pediatric population. That's why the evidence in pediatric population is quite sparse. However, there are evidences, particularly in population who are adolescent population. So whatever the evidence, they say that if there is a ferromagnetic material, intracardiac line, intracranial pressure is high, these are some contraindications. Suppose somebody is having a raised intracranial pressure and there is a ventriculoperitoneal shunting is there. So in those scenarios, it is better to avoid rTMS. So we are talking about how to select the patient. We select the patient on the basis of if there is a contraindication, we need to avoid. If there is an indication, then we need to think whether there is a contraindication or not. So it is all about thinking contraindications and indications. Now talking about when to consider rTMS. Can we consider rTMS as a standalone treatment? Can we start rTMS early in the course of treatment as an add-on therapy, which called as early augmentation of rTMS? Can we use rTMS only for the treatment-resistant cases? Mostly the recommendations, they talk about treatment-resistant cases. If you are talking about depression, OCD, all those cases, the evidence is the recommendation is you use rTMS if there is a failed trial of antidepressants, multiple trial of antidepressant and psychotherapy in depression, and multiple anti-obsessive medications has been tried in the treatment of OCD, and the behavioral intervention like exposure response prevention has been tried and unsuccessful. In those scenario, you can consider rTMS, but it is not a hard and fast rule to wait for treatment resistance. You can, there are some evidences that you can start early in the course of treatment. You can start rTMS as an add-on treatment. So in that scenario, the evidences support that if you start rTMS early in the course of treatment, probably you will be able to control the symptoms early. The patient can resume the functionality early. You can limit the disability, and there are so many advantages in terms of the outcome of the illness. So early augmentation can be one way of introducing TMS in the treatment area. Now the thing is, can we use rTMS as a standalone treatment? It totally depends upon the type of indication for which you are using. Suppose you are using it for depression or OCD or schizophrenia. There are many patients who are intolerant to the conventional modality of pharmacotherapy. They don't, we have used, in my personal experience, we have used TMS as a standalone modality of treatment in few of the patients, particularly those who are OCD and having OCD, they have severe intolerance to serotonergic medications. So they were not able to tolerate the medications. We cannot optimize the dose of medications. So we started with rTMS. And during the acute phase of treatment, the symptoms are adequately controlled. But the after effect of TMS after multiple sessions usually wanes off over a period of 8 to 12 weeks. So we require maintenance treatment for the continuous control of those symptoms. So these are the conditions where you can consider as a standalone treatment. It can be considered, but the evidences are quite few because mostly people use rTMS as an add-on treatment to the ongoing pharmacotherapy or psychotherapy. It can be started early in the course of treatment, but most of the evidences, they exist with respect to treatment-resistant psychiatric disorders. It is used for the acute management of the symptoms. In the acute phase, you give intensive therapy, at least 1 session per day, at least 5 sessions in a week, and total number of sessions at least ranging from 10 to 20 sessions continuously over a period of 2 to 4 weeks. That helps in acute control of the symptoms. But there are conditions where patients require a more number of sessions, particularly patients with OCD, patients with schizophrenia, particularly those who are having negative and cognitive symptoms. They require more number of sessions. Some of these patients, after discontinuation of rTMS, the symptoms again relapse. Then you need to consider maintenance treatment of rTMS, maybe 1 session weekly or 2 sessions weekly. Subsequently, you can plan to space the sessions of rTMS. So maintenance rTMS is one good strategy to prevent the relapse of the symptoms. And in our rTMS clinic, we are using rTMS for prevention of relapse as a maintenance treatment, and a quite a good number of patients are there for maintenance treatment of rTMS. Now, coming to safety of rTMS, it has been already been discussed by Dr. Anurag and Dr. Shruti that there are already safety screening questionnaires when you are using rTMS. That screening questionnaire need to be applied in every patient, whether there is any contraindication for rTMS or not. Those safety checklist is available in multiple. You can get it from multiple published articles. One of the initial article by Rogi et al. Andre Brunoni and Rogi, that they have the team, they publish a checklist. The mostly the contraindications of rTMS are similar to the contraindications of MRI, so you can refer to that. And rightly pointed out by Dr. Anurag that if somebody has undergone MRI in the recent past, fairly that person is fit for rTMS, you can go, because that person might have gone through that checklist of things before going for MRI. Now we'll be talking about after selection of the patient, how to decide the stimulus dosing for different psychiatric conditions. The stimulus parameters particularly depend upon you need to know about what is pulse, what is frequency, what are the number of pulses per sessions, what is the train, total number of pulses, daily frequency of sessions, how many sessions you give in a day, how many total number of sessions you give at a go. So these are all the parameters that are important when you are deciding the efficacy and evidence of rTMS in various psychiatric disorders. When you are considering rTMS for a research purpose, you need to take all this data into account for doing the analysis for predicting the outcome. So in the afternoon, we'll be having the hands-on training demonstration, during which we'll be displaying how to regulate the pulse frequency, how to set the number of pulses per session, how to set a protocol, all those things will be discussed. But in brief, I will be telling that pulse frequency can be broadly divided into, when we're talking about conventional rTMS, broadly we divide the pulse frequency into high frequency protocols and low frequency. High frequency is if the frequency is 5 pulses per second or more, it is high frequency. And less than 5 hertz, mostly 1 hertz, 2 hertz and 0.5 hertz are the 3 low frequency protocols commonly being used. 0.5 hertz means 1 pulse in every 2 seconds. So low frequency particularly target the GABAergic neurons producing an inhibitory effect, whereas high frequencies particularly stimulate the glutamatergic neurons producing an excitatory effect. Next is the number of pulses per session. What are the evidences? There are some evidence-based guidelines, recommendations. The first evidence-based safety and clinical recommendation of rTMS is published in 2014 by Lafayette et al. In the Journal of Clinical Neurophysiology. That is a classic article that every individual who is planning for rTMS, everyone should read that article. Again, that the updated article is published in 2020. That is whatever the evidences existing between 2014 to 2018. So rTMS consensus guideline. Subsequently, in 2023, Brunoni et al. They have also published a safety and a recommendation for use of TMS. The initial guideline, they support that to have an effective treatment with TMS, at least per session you need to give 1000 pulses per session. So 1,000 pulses or more pulses in a session, in a given session, is found to be more effective consistently. Then the number of pulses per train totally depends upon whether you are choosing a high frequency protocol or low frequency protocol. Suppose you are giving a high frequency protocol, particularly 10 hertz frequency, you cannot give more number of pulses. You need to restrict to 40 to 60 pulses in a given train. So if you give more number of pulses with high frequency, then there is a risk of seizure. So one need to be cautious. But if you are giving a low frequency stimulus, that is 1 hertz, 2 hertz, or 0.5 hertz, then you need to, you can keep more number of pulses in a train. Then again, the inter-train interval. So what is a train actually? Pulse is a single stimulus, a single magnetic stimulus. When you are delivering a stimulus, you will hear a tick sound. That tick sound corresponds to one magnetic stimulus. So the pulses are released in a sequential manner. So pulses are released in bunches. So you release 40 pulses simultaneously at a given frequency, then you give a gap. That gap is intertrain interval. Again, then 40 pulses will come. Then there will be a pause or a gap. Again, 40 pulses will come. Then there will be a gap. Why I'm talking about 40 pulses? Because this is the first US FDA approved protocol in 2008 for depression. They have used 10 hertz frequency, 40 pulses in a train. So 4 seconds will deliver 40 pulses with 10 hertz frequency. Then a 20 second of intertrain interval. A total of 75 trains. Each train delivers 40 pulses. So 75 trains will deliver 3,000 pulses over a period of 37.5 minutes. So that was a long train that is approved by US FDA high frequency protocol at 120% of the resting motor threshold over left dorsolateral prefrontal cortex. So when you are giving a high frequency protocol, you need to keep the intertrain interval bit large so that the neurons will reach a refractory to a stimulating pre-refractory state and they will respond to the stimuli. And second thing is there will be minimal side effect. That is, you can minimize the risk of side effect like seizure. But if you are giving a low frequency protocol, you can keep the intertrain interval shorter, as short as 5 seconds. Then total number of pulses, it is another indicator of treatment outcome. If you give more number of pulses, it gives a better outcome. There are some early evidences, but more research is required to substantiate these evidences. The evidences support that if you give, suppose somebody is receiving 10,000 pulses over a period of 2 weeks over 10 sessions, and somebody is receiving 20,000 pulses over a period of 2 weeks over 10 sessions. So if you are giving more number of pulses, total number of pulses, then the outcome is likely to be better. Then there are different frequency of protocols. Conventional protocols, they recommend 1 session per day, at least 5 to 6 sessions per week, and roughly a 10 to 20 sessions in total over a period of 2 to 4 weeks. When you refer to most of the Western literature, Western studies, most of the studies, they did 5 sessions in a week, because there are 2 weekdays that are weekend days. The TMS is not being delivered, so they usually classically deliver 5 days a week session. But there are many setups where the setup is open all the 7 days or 6 days a week. So it is not a contraindication that you cannot give 6 sessions in a week or 7 sessions in a week. You can do, but 5 to 6 sessions are mostly evidence-based supported sessions, 5 to 6 sessions in a week, when you are following a conventional procedure, 1 sessions daily. Then if you are giving more, you can give more than 1 sessions in a given day. That is classically called as accelerated protocol. In our center, we have given mostly we give accelerated, mostly more than 1 session per day. It can be safely delivered. Very recently, the Stanford protocol, that is by the Saint protocol, that is approved during 2020. it gives that you can give more than around 10 sessions in a given day, and a total of 50 sessions over a period of 5 days. So it is found to be quite safe and US FDA approved. So accelerated protocol can go up to 10 sessions in a given day. The total number of sessions conventionally, it is in the across the studies for various psychiatric disorders, they used 10 to 20 sessions over a period of 2 to 4 weeks. But you can extend the number of sessions beyond 20. If you are extending beyond 20, it is called as an extended protocol. If you are giving 20 daily sessions over a period of 4 weeks and beyond, more than 20 daily sessions. So extended protocol is required for particularly those individuals who are having long-standing refractory depression, individuals who are having negative symptoms of schizophrenia, and particularly patients with refractory OCD. Now there are some tasks for the audience, but because of the time paucity, I'm skipping all those things. I may skip few more slides in between because they are being discussed by the previous two speakers. So when you are talking about setting a protocol, it is important to understand the resting motor threshold. Resting motor threshold is every individual is having a different resting motor threshold. This is the threshold at which the 50% of stimulus are being responded by the neurons. So when you are identifying the resting motor threshold, we give 10 stimulus to a given area, particularly the motor area, and we look for contractions in the hand area, particularly motor contractions, either through the EMG or through visual contractions. If you are getting 5 effective contractions or 5 deflection in the EMG with a amplitude of more than 50 microvolt, we call them effective contractions. And there should be at least 50% of the stimulus need to be responded by the neurons. So every individual is having a specific resting motor threshold, and resting motor threshold is something which is a very dynamic phenomenon. It keeps on changing from time to time in a given individual. Like suppose somebody is deprived from sleep, the resting motor threshold will be low. Suppose somebody is taking benzodiazepine or any anti-epileptic medication, the resting motor threshold will be high. Suppose somebody has consumed alcohol last night, because of the GABA or glutamatergic activity, the resting motor threshold can be altered. So one need to estimate the resting motor threshold on regular intervals before delivering the TMS. And one good thing is, suppose you are doing it for a research purpose, it is better to do the estimation of resting motor threshold on daily basis. If you are doing it for a clinical purpose, maybe every 3 days or in a week, we need to estimate the resting motor threshold. What happens to the resting motor threshold in the due course of therapy? We all know that when we are giving electroconvulsive therapy, the threshold of the neurons keeps on increasing after multiple sessions of ECT. But here, a different thing happens. When you are giving rTMS during the course of treatment, the frequency, the resting motor threshold gradually declines. So one need to be regularly monitoring for that. Then priming is another technique to optimize the effect of TMS. So priming is basically, suppose you are giving a priming for the high frequency stimulus. Suppose you are giving a priming for the low frequency stimulus, the priming technique is different. Suppose you are targeting priming for high frequency rTMS in depression. So you have to give a low frequency protocol over the left dorsolateral prefrontal cortex. After that, you have to give a high frequency protocol. So you do the priming with low frequency protocol for a subsequent high frequency protocol. Suppose you are giving low frequency rTMS for OCD and you want to do a priming, then you do a high frequency of 6 Hz frequency, 600 pulses priming over the supplementary motor area, then you run the low frequency protocol. So a stimulatory protocol requires priming with an inhibitory protocol. A inhibitory protocol requires priming with a stimulatory protocol. This is the dictum. Theta burst stimulation is another modality of TMS where pulses are released in burst, not in pulses. So they are released in burst. So 3 pulses in a go. then they are having a frequency of theta. The burst is released in a theta frequency. So theta frequency is ranging from 3 to 8 hertz. So classically theta burst stimulation releases the burst at a frequency of 5 hertz. So continuous theta burst stimulation and inhibitory theta burst stimulation are two types of theta burst stimulation. Continuous theta burst stimulation gives a inhibitory effect, whereas intermittent theta burst stimulation gives a stimulatory effect. So intermittent theta burst stimulation is almost similar to high frequency rTMS. Continuous theta burst stimulation is almost similar to low frequency rTMS. Then regarding combining different protocols. So we discuss about priming. Priming protocol is a combination of protocol, high frequency and low frequency protocol. Sometimes you have to do a sequential stimulation or a multi-site stimulation. Particularly, people do multi-site stimulation when they are treating patients with schizophrenia. The common multi-site targets are you target the left dorsolateral prefrontal cortex with a high frequency protocol followed by low frequency protocol over the left temporoparietal junction. So this is a sequential stimulation of two sites in a given session. You can do the multiple protocol for treatment of depression. Like you are targeting the left dorsolateral prefrontal cortex stimulatory protocol by giving intermittent theta burst or high frequency rTMS, then switching to the right DLPFC by giving a inhibitory protocol. So it is a sequential stimulation by using two different protocols. Suppose you are treating tinnitus, you can do a multi-site stimulation with a sequential different protocol. Suppose you are treating Parkinson's disease, you can do the multi-site stimulation. So there are various conditions where you can do combination of protocols and use in a given session. Then coming to booster sessions. Booster session basically refer to the maintenance rTMS. It is basically aiming at preventing the relapse of the symptoms, particularly in patients with depression, OCD, schizophrenia. Commonly, people do the maintenance rTMS sessions. Multi-site stimulation that we have already discussed. Then combining TMS with TDCS. This is another newer area of research where people started using TDCS and TMS simultaneously. TDCS can be used as a priming modality. TDCS is transcranial direct current stimulation. So there is a cathode, there is an anode. Cathode produces inhibition and anode produces stimulation. Suppose you want to do a priming not by using TMS, you can do the priming by using the TDCS. You have given a anodal stimulation by giving TDCS as a priming technique. After that, you have given TMS low frequency. So you stimulated with TDCS, then inhibited by rTMS. And vice versa also you can do. You stimulated with the rTMS, then subsequent inhibition therapy was being delivered by TDCS. So combining different modalities are also being tried successfully with safety ensured. Now quickly we'll talk about different evidence-based protocols. Depression is one of the commonest indications where rTMS is being used. Common target is right dorsolateral prefrontal cortex and left dorsolateral prefrontal cortex. If you are targeting right dorsolateral prefrontal cortex, you need to give low frequency or continuous theta burst stimulation. If you are giving a high frequency stimulus, then you need to choose the left dorsolateral prefrontal cortex. The commonly used frequencies, high frequencies are 8 Hz, 10 Hz, 20 Hz. Among these three, 10 Hz is the most commonly being used. It is being approved by US FDA in 2008. 10 Hz frequency, 40 pulses in a train, 75 trains, total of 3000 pulses, 26 second intertrain interval. So total of 37.5 minutes protocol, and it need to be repeated over 20 days for 20 sessions. Intermittent theta burst stimulation is an alternative to this high frequency protocol, which is being approved after 10 years of the first approval, that is in 2018. Here you can deliver the pulses over a period of 3 minutes by using the theta burst stimulation. Here 600 pulses are being delivered over a period of 3 minutes. So it is curtailing the duration of treatment. So it is more time convenient for the patient and as well as for the therapist. The response rate, many RCTs has been conducted. They found that with the active TMS, the response rate is nearly 3 times higher than the SAM TMS. Usually people have used a stimulus intensity of 80 to 120 hertz, 120% of the resting motor threshold. So particularly if you are delivering low frequency rTMS, then go for a sub-threshold stimulus, maybe 80%, maybe 90% of the resting motor threshold. Suppose you are giving a high frequency, then go for a supra threshold, that is 110%, 120% of the resting motor threshold. So resting motor threshold, we have already discussed that for a given individual, resting motor threshold, you need to identify. Suppose you identified the resting motor threshold in my brain, and you identify it to be 50. 50% of the output, that is 50 amplitude. My resting motor threshold is 50, which is corresponding to the optimal resting motor threshold, that is 100% of my resting motor threshold. If I need to receive a therapy at 120% of the resting motor threshold, then 120% of 50 will be 60. So we have to deliver that therapy at 60 amplitude. Similarly, if you have to deliver it at 80%, then it will be 40. The total number of sessions given in majority of the research ranging from 5 to 30 sessions for treatment of depression. There are several parameters. You can use various parameters to predict the outcome of response. Parameters can be related to the coil placement, parameters related to the TMS parameters. There are some approved indication related parameters, mostly related to if you are giving a high frequency rTMS, then go for threshold or supra threshold. Pulse frequency, if you are going for low frequency, then go for 1 hertz or less frequency, targeting the right dorsolateral prefrontal cortex. If you are going for a stimulatory protocol, use 5 to 10 hertz frequency, preferably 10 hertz frequency, targeting left dorsolateral prefrontal cortex. Considering the safety, you need to have a shorter intertrain interval for low frequency protocols and longer intertrain interval for high frequency protocol. High frequency protocol, more of left dorsolateral prefrontal cortex, low frequency for right dorsolateral prefrontal cortex. So it is more of a laterality related placement. So these are some already approved indications that are available online. You can refer to those indications. No need to remember all those things. These are given, all these protocols which is available. If you have a TMS lab, you can paste all those essential things in the lab so that readily you can refer to those things. What are the approved protocols? What are the coil positions? How to locate those important brain areas for different conditions that need to be a part of your reference manual in the TMS lab. There are various accelerated protocols that are being used for treatment of depression. Some of the accelerated protocols, they used high frequency, low frequency rTMS. People also used accelerated protocol using continuous and intermittent theta burst stimulation. Protocol duration ranging from 10 to 30 minutes. So various techniques has been used for identifying the targeting brain areas, particularly DLPFC. One of the commonest used method is 5 centimeter or 5.5 centimeter method. Dr. Shruti has already talked about that. You have to identify the vertex and 5 centimeter laterally. You have to take a point across the intertragal line. You have to mark that point. Then again, you have to take a point 5.5 centimeter anterior to that point. That is going to give you the dorsolateral prefrontal cortex. BEAM-F3 is another software that is freely available where you consider 3 parameters: Nagion-Union distance, intertragal distance, and head circumference to identify the dorsolateral prefrontal cortex. Neuronavigation is the most accurate method of identifying the dorsolateral prefrontal cortex, but you need functional MRI, and you need to take the skull configuration and superimpose that skull configuration with the functional MRI generated skull size, and you need to identify. Treatment dose need to be considered, identifying the motor threshold. So mostly the therapy is being delivered during the resting state, but now a lot of research are coming when people are using TMS in an activated state by engaging the patient in some cognitive task. So task-oriented, activated brain areas are being modulated. The recent approval of the accelerated protocol is the SAINT protocol, Stanford Accelerated Intensive Neuromodulation Treatment Protocol, SAINT protocol. This targeted the F3 location, that is left dorsolateral prefrontal cortex. 1800 pulses are delivered in each of the TMS sessions over 10 minutes, and 10 sessions given in a given day with a inter-session interval of 60 minutes. One session given, after 1 hour, another session is given, and over a period of 10 hours, 10 sessions are given in a given day. And over a period of 5 days, 50 sessions are being delivered. And you see the interesting outcome. If you see the acute response, the conventional rTMS protocol of 4 to 6 weeks, it gives a response remission rate of 30%. If you are giving a electroconvulsive therapy for treatment refractory depression over a period of 2 to 4 weeks by alternate day ECT or 2 ECTs per a week, then you get a response of 50% remission. But if you are using SAINT protocol by using intermittent theta burst stimulation, you get a response remission rate of 80%. So we have something better than ECT now by using neuromodulation. But this protocol, though it is approved during the COVID time in 2020, but it was not replicated in multiple scenarios. It is people are carrying out multiple clinical trial to using the SAINT protocol to see its efficacy. It is in progress. We can predict the response to rTMS in various psychiatric conditions. There are some measures by which you can predict that who are those individuals who are going to respond to TMS better, and who are those individuals who are going to respond to TMS not the result will not be that encouraging. So negative predictor and positive predictors that are already known from evidences. The predictors can be neurobiology related, like receptor related predictors, neuroimaging related predictors, like what is the metabolic activity in different brain areas, glutamatergic activity, glucose metabolism related activities, and the volumetric assessment, volumetric dimension of different brain areas. Then electrophysiological also you can predict, like before doing the TMS, you can do a EEG and you can quantify. Quantitative EEG can give you an idea about what is the different waveforms or different cortical activities in different brain areas. Accordingly, that can give a prediction about the outcome. TMS related techniques and various other concomitant antidepressant treatment and duration of depressive episode, all these parameters, they predict the outcome of response to TMS. Similarly, people used various level of evidences, identified various evidences with respect to use of TMS in schizophrenia, TMS in OCD, TMS in bipolar disorder, PTSD. So I'm just quickly skipping all those slides. So this is available in this article, that is effect of therapeutic use of TMS in psychiatric disorder, an evidence-based review. You can refer to this article. You will get the evidence, level of evidence, what is the target area, and what type of TMS strategy you need to follow for that, and what type of symptoms particularly improve with these interventions. Now coming to use of TMS and OCD, this is another area where TMS is being commonly used. Corticostriatothalamocortical circuit is being involved, so you can target the different areas. Common areas targeted are orbitofrontal cortex, supplementary motor area. Other than these two areas, dorsolateral prefrontal cortex and pre-supplementary motor area, dorsomedial prefrontal cortex are also being tried in patients with OCD. So recently we conducted a umbrella review of meta-analysis related to rTMS and OCD. Umbrella review basically refers to the systematic review of the meta-analysis. So it is still one step higher, the evidence of meta-analysis and systematic review. So this is the first umbrella review of meta-analysis related to use of rTMS and OCD. And we analyzed 12 meta-analysis in this study, and the common target areas are DLPFC, supplementary motor area, orbitofrontal cortex. There is a lot of heterogeneity in all the 12 meta-analysis that are being included. the thing is, initially people suggested that DLPFC may not be the good target area to deal with OCD. Non-DLPFC target like supplementary motor area and pre-supplementary motor area may be a better target. But subsequent evidences that support that, why the negative result were there with DLPFC, because these studies were limited by small sample size. When they tried to replicate those studies with a larger sample, they found that dorsolateral prefrontal cortex neuromodulation is equally effective than supplementary motor area. So DLPFC, supplementary motor area are equal effective target. If you are targeting the dorsolateral prefrontal cortex, then target the left dorsolateral prefrontal cortex with a stimulatory protocol. If you are targeting the supplementary motor area, then target it with an inhibitory protocol. So maybe in low frequency rTMS, maybe continuous theta burst stimulation for supplementary motor area, intermittent theta burst stimulation, or high frequency rTMS for the left DLPFC. Now the deep TMS, ma'am is going to talk about the advance of TMS. Deep TMS is one of the advancement in the TMS procedures. H1 coil is meant for the major depressive disorder, H7 coil is for OCD, H4 coil is for smoking cessation. So deep TMS gives better penetrability, around 5 centimeter penetrability if you are using deep TMS. But if you are using a conventional TMS coil, the penetrability is limited to 2 to 3 centimeters. So in schizophrenia, people used rTMS, particularly targeting the left temporoparietal junction or bilateral temporoparietal junction by using a low frequency rTMS, mostly a subthreshold intensity. There is a dictum like, suppose if it is salient auditory verbal hallucination versus non-salient auditory verbal hallucination. What is salient auditory verbal hallucination? If auditory verbal hallucination is associated with some emotional component, a component of emotional distress, so that is salient auditory hallucination. Auditory hallucination may not be producing significant emotional distress, so that is non-salient auditory hallucination. People differentiated that presence of salience with auditory hallucination determines the laterality. Like suppose there is a salient auditory verbal hallucination, maybe the suitable target is right temporoparietal junction. If there is a non-salient auditory verbal hallucination, maybe the target is left temporoparietal junction. So this is how presence of salience decides which target need to be done, which area need to be targeted. We also wrote another interesting article. Can we predict the response to TMS when you are treating auditory hallucination in schizophrenia? There are a lot of evidences, like suppose somebody is receiving some anticonvulsive drugs that reduces the efficacy of TMS. Anticonvulsive drugs like valproate, lamotrigine, carbamazepine, if they are given for treatment of the comorbid affective symptoms, if anybody is asking any question to me, I can take the questions at the end of the session. Then low frequency rTMS with a high number of stimulation per day over the left temporoparietal cortex is another technique which predicts a better response. If you are doing a neuroimaging guided high frequency rTMS over the posterior part of the supratemporal sulcus, then that gives a better response. So these are various neuroimaging, frequency related, laterality related targets that predict the outcome of auditory hallucination treatment with rTMS. rTMS has been tried in patients with addictive disorders. Evidences support that it is effective in alcohol use disorder, tobacco use, cannabis, cocaine, stimulant use, opioid use. Many studies, they used single session of rTMS for the treatment, and many used the multiple sessions. It is always better to have multiple sessions, but multiple sessions, they give a relatively better result than the single session of rTMS, because multiple sessions helps in development of neuroplasticity. Then when you are using conventional TMS and theta burst stimulation or deep TMS, you need to choose different protocols. Deep TMS particularly gives a better penetrability, and it is FDA approved in 2018, and it is using the H4 coil particularly for smoking cessation. The target symptoms when you are treating an addictive disorder is mostly craving related symptoms, but it has been seen that those who are receiving TMS for treatment of addictive disorders, The total amount of substance consumed in due course of time significantly reduced. The duration of abstinence also significantly reduced. The cognitive symptoms or cognitive errors associated with the addiction or the affective symptoms associated with addiction, they are also significantly reduced. People try to identify different predictors associated with response to TMS in addictive disorders, referring to EEG changes, dopamine transporter, dopamine modulation, blood oxygen derived different signal, bold signals, and they predict it is in process. I didn't found any study clearly mentioning that these are the predictors that predict the outcome of TMS treatment in addictive disorder. Maybe you can write another article, you can submit to Global Psychiatry Archives. Professor Reiner, who is the editor-in-chief of Global Psychiatry Archives. So rTMS, when it is being used in substance use disorder, the common target areas are dorsolateral prefrontal cortex. It can be right, it can be left, or bilateral dorsolateral prefrontal cortex. Medial prefrontal cortex is another area, insula is another area, anterocingulate cortex, dorsal anterocingulate cortex. Particularly when you are using deep TMS, you can target insula and anterocingulate cortex because these areas are particularly deep seated, and probably you require deep TMS with a better penetrability to have the therapeutic effect. Here I will close. We know that rTMS is increasingly being used for a variety of psychiatric conditions, and the success of therapy depends upon a large number of things. You need to choose appropriate patients for the rTMS therapy. You need to do a appropriate protocol, appropriate target area need to be selected, and you need to choose a protocol that is supported by good evidence backup. A lot of protocols are available when you are referring to the guideline. Recently in 2023, Indian Psychiatric Society has also published a practice recommendation for use of rTMS for neuropsychiatric disorders. This article is being written by Dr. Sai Krishna Tikka, Dr. Sovit Garg, Dr. AIIMS&GPA and their team. You can refer to that article. That is interesting article with all the evidence backup, when to use, how to use, why to use, and which protocol to be used for a given condition. Thank you so much. We'll take questions at the end of the session, probably.
Is my understanding, do we have questions now, or do we have questions at the end of this session?
We are going to have the final session now, sir. After this session, we'll be taking the questions from the audience.
Okay. Thanks, Sujit, for this excellent talk. And yeah, you're welcome to publish in Global Psychiatry Archives. Thanks a lot. And then questions are at the end.
Thank you.
A big thank you to Professor Sujit Garg for offering much needed clarity, a detailed discussion, and insight on this complex topic. Thanks to Professor Heun for chairing the session. Now we move on to the final academic session of the morning by Professor Mona Srivastav, who will present on recent advances in rTMS that will provide us updates on innovation and future directions. The session will be chaired once again by Professor Sujit Garg. As the Professor Garg have been introduced already, I would directly invite the Professor Garg to introduce our speaker and invite him.
Good morning again. It's a great pleasure to introduce Professor Mona Srivastav. He'll be talking on the topic recent advances on rTMS. Professor Mona Srivastav is the ex-head of Department of Psychiatry, Institute of Medical Sciences, Banaras Hindu University. He is MD Psychiatry from NIMHANS, Bangalore, and her area of interest is child psychiatry, mood disorder, genetic basis of psychiatric disorder, and de-addiction. She got several gold medal and multiple awards in different forums, and Madam is having more than 100 publications and several book chapters and 3 books, and she is a well-known researcher and teacher in the Indian Psychiatric Society. She has presented in multiple national, international scientific forums and she's the editor and assistant editor of a couple of national international journals. Is the ex-nodal officer of National Mental Health Program related to Center of Excellence in Psychiatry at AIIMS&GPA. Over to you, ma'am. We welcome you for having your presentation.
So at the outset, a very good morning to all of you, and I must congratulate the organizers because this is one of those rare conferences which is going prior to the time allotted. Otherwise, we are usually late. So just before I think it is not the time for lunch, so everyone should be a little stimulated to hear the presentations. And I must thank Dr. Smiti and the Department of Psychiatry at Raebareli to have organized this and to have invited me for this presentation. Again, like Professor Anurag said, this is again a disclaimer because the Department of Psychiatry at AIIMS&GPA has recently acquired the rTMS. We are just a baby, around 4 to 6 months, and because of certain glitches, technical and red tape, it has only started functioning for the past 3 months, 3 or 3.5 months, and we have now 2 people who are working. One is on smoking and the other is one MD psychiatry candidate who has been given. So we don't have that amount of experience or data of literature as Professor Kar was saying. So we are really enlightened and to hear from him. So I thank all my prior speakers. They have made my work much easier because I'll be skipping through so many slides, but I had to add them because for the need for completion. So I think we'll start it. So this will be the outline of my presentation. Again, the history. So we owe it to David Cohen, who gave us this machine. And then this is in the outline of how history has been there. So we start with Faraday, who gave us the electromagnetism, and then now we have the FDA approval. So these are the various highlights of the timeline through which we are now with the rTMS machine. This is again David Cohen. The introduction to rTMS. So sorry for the interruption, but again, we start. So transcranial magnetic stimulation, most of us know and has been presented by my previous speakers. Like I said, my task is much easier now. So this is a longish slide. Suffice it to say here that the rTMS actually stimulates the neurons and turns the synapses. And these may be long-lasting changes because neuroplasticity comes into functioning. Again, this is a simpler version of how rTMS functions, and evoked potential has been explained by my previous speaker, Professor Kar. So this technique is again an outpatient technique, which is simple. The person walks in, has it, and can walk out. So that is precisely the reason why Monday to Friday is actually given, because Saturday, Sunday is non-working days for people abroad. Again, this is the type of IMS which these are slides basically focused for the residents to make it a little simpler. This is a single pulse TMS, then we have a paired, and then we have a repetitive, which is higher frequencies for cortical excitability and the lower frequencies for cortical inhibition. So the accessible areas, I just wanted the residents to know what are the DLPFC, the SMA, the SFG or the TPJ, all these areas they should be aware of. Again, the localization of target has been explained so lucidly by Professor Carr, and these again I will just skip through the slides because the 5 centimeter rule or the beam F3 system, which is responsible for us locating the target area. And most recently we have the neuro navigation, which is the best way. And about a couple of weeks prior to coming here, we've had our hands on the neuro navigation machine as well. So these are the various types of coil which have again been explained by all the previous speakers, including Dr. Carr and Dr. Smiti. So I won't be going, and these are the common stimulatory packages which are there. Then these have again been explained by my speakers. So the 10 hertz stimulation or the 1 hertz stimulation, intermittent theta burst, and the continuous theta burst stimulation. All the protocols, etc., have been explained so well and so lucidly by my prior speaker, Professor Carr. So again, indication, these are all repetition slides. So I'll quickly go through all of them. Contraindications again has been, there are only one absolute contraindication, and that is whether we have a metallic hardware in the close vicinity, like a cochlear implant or the internal pulse generator or any other implant. Other very interesting a contraindication if somebody has a metallic tattoo. So that also has to be kept in mind, because nowadays we have people who come with a lot of tattoos around. Then in rTMS, depression indications, treatment resistance, intolerance to medication, or it can be an adjunctive therapy or the maintenance therapy. Again, the protocols and depression has been so lucidly told by Dr. Carr. The various mechanisms of action which are responsible for the rTMS antidepressant are ranging from the neurotransmitter to the neural circuits to the hippocampal neurogenesis, and also they have a molecular pathway which targets the BDNF. So it has a whole gamut of action responsible for the antidepressant effect, not only the serotonin and the classical neurotransmitters, but it goes on to even the molecular pathways, which actually make it quite an effective tool for therapy in as an antidepressant. So again, this is a continuation of the slides on the antidepressant action, that it enhances the cerebral blood flow, also the transsynaptic global metabolism, and then there are certain connectivity changes which have been touted to be present when rTMS is given. Now, this is a very interesting diagram. Actually, if we look at what we have as symptoms and signs of depression, so we are targeting just a very small area, but the connections are so wide. So we have certain areas which target the psychomotor symptoms, then the cognitive, the emotional, the neurovegetative. So one can argue why a small area. Well, area is an area which has such ramifications and connections to so many multiple areas which are responsible for various other symptoms and signs which do occur in depression. Even if we look at it, there are certain symptoms which are a part of OCD or an anxiety, or we have psychomotor symptoms as a part of schizophrenia, cognitive for dementia. So that is precisely the reason why rTMS can be so good at providing treatment as an adjunctive treatment for various other disorders. So the areas and effects, well, DLPFC, that is the baby, that is such a prime area. It is for addresses the frontal hypoactivity. Then the right DLPFC, as was mentioned by Professor Carr. Actually, Professor Carr has made my work so easy. So thank you for making that. And those are the other areas which are present, and their functioning has been elucidated and highlighted. So these are the treatment protocols. Again, this is a repetition of what has been talked about. So I think I will skip. People who are interested can always take a photograph. Otherwise, it is all there in the journals. again, like was talked about, these are various protocols which are commonly given. Saint protocol is one protocol which is now a very favorite protocol. What is concerning is that in West we have this insurance coverage by insurance. We don't bother about insurance so much, but the Western counterparts, etc., they have a lot of issues with insurance. So which protocols are covered by insurance, that becomes their very primary area of interest. So we have this typical ITBS, intermittent theta burst, which is often covered by insurance. Other parameters can be seen in the slide, but one particular like loophole or a limitation can be coverage by insurance. So they become a lot of experimental rather than being a run-of-the-mill phenomena. These are the certain regulatory guidelines which have been published and which are there available, and these are the Clinical rTMS Society's treatment guidelines. Then this was in Neurophysiology 2020, the International rTMS Consensus guidelines, which was published. So as per these guidelines, and like Professor Ka was saying, even the Indian Journal of Psychiatry recently, 2023, they have published their own guidelines. So I think the residents should go back and read, and all those people who are interested in working should be aware of these guidelines. So side effects, again, this is just a repetition of what has been talked about. Complications, the serious complication is seizure, which is very, very rare, and local pain or tinnitus and hyperacusis can occur, which are all transient. They get over with time. Only seizure is one thing which should be taken care of, and a proper history and a proper filling up of the form, like Dr. Anurag Varma had talked about, can regulate this particular complication. So again, application for TMS, it is a therapeutic tool. It can be a research tool. And neurology is also very excited about this, and they have so many indications for rTMS. And recently, in from the Department of Neurology at AIIMS, we had a conference where they had a full session on rTMS in Parkinson's and dementia and in movement disorder. Then Tourette disorder, of course, it is there, and that was a very good session which they had. They had actually done a hands-on training and a demonstration of its effect. So again, neuromodulation and plasticity, as I have talked about in the antidepressant action, this is one of the action which is a longer lasting action. But subsequently in dementia, in elderly especially, neuroplasticity has been shown to be very less effective, because probably it is age related, and the amount of plasticity does not occur at that point in time in the age. So precautions, again, I said, like this has already been talked about, and so determinants of better response, like it was already talked about by Professor Kar, from the person related to machine related to illness related, and even at the molecular genetic related. So we have the CC homozygosity and L genotype for transporter gene, and if a good neuronavigation is provided, then that actually predicts a better response. Examples of rTMS devices are just for a theoretical purpose, and the treatment procedure is like a person comes, a full course should be given. That is very, very important. If supposing halfway the treatment is done, like any other treatment, the chances of success are limited. So we should be very careful if we tell the patient that, see, if you have to undergo this treatment, you should take care to take the entire full gamut of treatment rather than dropping in between. If one drops in between, then probably the chances of good efficacy is limited. So who does it? Well, it is a physician who does it, and under the physician's guidance, a technician can be there and takes over. But it is not only a technician's job, so it should be primarily a rTMS physician. So how is it done? Well, individuals are made to sit on a comfortable chair, as was there on the paper, on the floor, and the patient should be awake. The patient is relaxed, and sometimes the people may complain about the ear disturbance, so they can be offered earplugs. Most often our patients do not require earplug, and sometimes they have this sensation. If anybody has that sensation of khatta in that teeth, that kind of sensation is there in when electricity passes through. So that kind of a sensation is there. Apart from that, there are no other problems which occur, but this is how flow of treatment goes, and this is how it is administered. Well, rTMS and medications, do we continue the medications? Well, yes. If the person is stable on medication, it would be advisable to continue medication along with rTMS. And during the process or the course of treatment, if possible, it is advised not to alter or not to change any medications. And sometimes people are required to be stable for 4 weeks on medications prior to starting. But if we say that we are giving it for a treatment resistance, then also if the person is sort of maintaining on the treatment and we want to boost up this particular person for therapy, then also one person needs to be well maintained on medication. We may not be required to taper or stop the medication. That is the point which should be given. rTMS as a research tool, well, it is now, I will just show one slide and one figure from IJP to 2023. The amount of publication has gone up by leaps and bounds regarding rTMS. So we have this baby. It is not a new baby, but this baby is there whom we are sort of nurturing very fast, and probably it will be later on a future recipe for a good recipe for treatment, because in psychiatry we keep on taking something and picking up things which will improve the lot of our patients. Our primary focus is that. So this is our department of psychiatry. Again, in antidepressant response, this again, I review of certain studies. Now, this was a very good study in the Canadian Journal of Psychiatry in 2023 on depression. They divided the studies into 5 categories. One was the first generation. Somebody is very angry. And the second was the second generation. First generation was less than 10 sessions. Second generation studies were for more than 10 sessions. The third generation they had combined like a bilateral rTMS. And then the fourth generation they looked at the meta-analysis. And again, the novelty of studies was the fifth generation. Now, what were the first generation studies the reports were sort of equivocal, not very heartening. But the second generation, again, the results in the high frequency were giving a lot of substantial therapeutic efficacy. And the third generation studies were again, like these were bilateral sort of experimental studies. And there were a couple of limitations to these studies, like they were not compared with the sham rTMS, and they were not conducted for more than 10 days. So there were some substantial limitations to these studies. So also that was not very confirmatory in their result. Meta-analysis, there were 8 meta-analysis that these researchers evaluated, and the analysis of antidepressant effect was mostly on the DLPFC rTMS and high frequency for the more than 2 weeks. Then depression and ECT. This is just a slide for the residents, how ECT differs from rTMS. We can say rTMS also involves a lot of current, magnetic, and then leading to current, and ECT we give direct current. So ECT, there are so many limitations. We have to anesthetize, we have to prepare the patient has post ECT, so many side effects, patients have a lot of stigma, and we need a lot of preparation for an ECT. On the other hand, rTMS is a simpler version, but the response and the range of response with ECT is slightly better than the rTMS. not very encouraging, but yes, by and by, as rTMS progresses further, I think we will be sort of giving away or getting over with ECT. But ECT is a very good treatment modality. So if somebody is there who has a lot of stigma or a lot of inhibition, one should try and get over it. So now I'll come to the other illnesses which have shown. I was primarily asked to talk about clinical updates, which will come later on. So these are certain very recent studies which have focused on various different disorders in psychiatry. So we have our bread and butter mostly is schizophrenia. So this is Psychiatry Research 2014, the effect size for alleviating the negative symptoms. Most of the studies which have been done on schizophrenia have found that the negative symptoms, the executive functioning, the working memory and language are the ones which are targeted and which are beneficial more often than the active and positive symptoms. In the positive symptoms also we have auditory hallucinations, which are more responsive to rTMS than active delusions or any other thought disorder. So this should be kept in mind. We have to choose the patient accordingly if we have to get a good result out of rTMS. In the bipolar affective disorder, there are so many studies. Then there was an RCT which showed that in bipolar, the rTMS is effective in specific phases of the disease. Now, which would be the specific phase? Obviously depression, but there are so many studies which have shown efficacy in mania also. But we can understand the operational procedure for administering rTMS into a manic patient becomes a little difficult. Person has to sit still. How many of our manics do sit still until we sort of sedate them? And then that becomes sort of a limitation. But nevertheless, there are studies which have shown that results on manic disorders is also good. And the results are still very heterogeneous, and certain protocols which have a homogeneity in their presentation have to be sort of developed. Then again, rTMS is considered a cognitive enhancer, even in healthy subjects. Now, that doesn't mean that all of us start getting an rTMS just to increase our memory, or just prior to the exam, we have this session of rTMS. Now, that is not there because we don't have that much rTMS. Probably one day we might. So Dr. Kar is there. He is an active researcher. So we can hope and put our hopes on him. So again, this was bipolar mania in 2021, as I was talking about. They have shown that their sham, in comparison to sham, the DLPFC was much better. So again, these are very few studies on manic. Most of them are focused on depression and suicide. This was a Journal of Clinical Psychiatry. Then they showed that in subjects who had suicidal ideation, if rTMS was given, the completion of suicide was much less. So this is one very heartening thing, because in suicide, we often say that ECT is the emergency treatment for a suicidal ideation or an acute suicidal individual. So OCD, like it was talked about, depression and OCD are two very, very important illness which are now a target of rTMS. In this neuropsychiatric disorder 2018, they said that the FDA cleared a kind of a recipe, like tadka and all that, recipe for OCD. Now this recipe is that there should be an rTMS device which should be brain-based. There should be an H7 coil, and then the high frequency stimulation more than 20 hertz, and the dorsomedial PFC or ACC should be targeted. Now this, if all these are combined, it kind of becomes a recipe for OCD treatment. Again, in Frontiers, we found that elderly showed increase in symptom severity, not stability after rTMS. And probably this was because of their age and the brain, the limitation of brain plasticity. Again, this study in biological psychiatry showed that there was a greater improvement if there was comorbid depression. And this is again self-explanatory because we are targeting so much on depression. So OCD with depression would perform better with rTMS. Now, these are the clinical predictors of who responds to OCD. If a person has OCD, who are the people who would respond much better? So they found that obsessional severity, resistance, disturbance, and interference due to obsessions are resistant against compulsions were the items which predicted a better response on the Y box. So the choice of patients can be done and limited. Dementia. Now, there are, starting from certain case reports to some RCTs, there are multiple, the research is, literature is replete with a lot of studies. Now, one study in, like this was showed us stronger DMN connectivity at baseline. This Alzheimer's research and therapeutics in 2025. This was a 52-week. They showed a better connectivity in the percutaneous. So again, one study, this was done in a single memory clinic at Korea. Now, this is something which they have done, which was very interesting. That what they did is that they did the hippocampal network was targeted by rTMS or a sham stimulation. And the fMRI connectivity analysis revealed that rTMS increased the functional connectivity between the hippocampus and the percutaneous. Now, this is a single study from a single clinic in Korea, but it has to be replicated further. But this was something which was very, very important, very, very interesting. And they also showed it that there was an improvement in the ADAS-Cog, that is the scale, which is done to measure as like dementia. This has two components, the ADAS-Cog and the ADL, that is activities of daily living. So they showed that there was a substantial improvement in the cognition along with the increase in the connectivity at the hippocampus. Other psychiatric disorders like sleep modulation, there have been multiple studies, and this facilitates plasticity, learning, subsequently improving the effectiveness of rTMS in the sleep modulation. In catatonia, there are a couple of case reports which have shown that rTMS can be very effective in catatonia. But this amount of evidence is actually limited to case studies. No like open label or double blind or RCT, so those are lacking. Again, in insomnia and MCI, again there are in REM and non-REM, there are stages, techniques, and neuromodulation where the patients are shown to show some improvement. In addiction, as was talked about, addiction is the new baby which rTMS, especially nicotine. We also have one study which is ongoing for nicotine, and this has started. This study, especially the Annals of New York Academy of Science, they had taken 19 human studies, out of which they involved 9 studies for tobacco, 6 for alcohol, 3 cocaine, and 1 methamphetamine. Mostly all these individuals were shown to have a good response to rTMS, but they concluded that this is still in the experimental phase. So again, this study was stimulation, promising treatment for craving and stimulant drugs. And this again was a meta-analysis which showed that there are different combinations of target, and the frequency stimulation is also different. Dr. Carr had already elucidated that there are protocols which have to be designed. So this was also a conclusion of these studies. I think this, where is that? So this is rTMS in special populations, especially in adolescents and children. Now, still we do not have an FDA approval, but there are so many studies which have been done. And this is a Journal of Affective Disorder, wherein they showed that the adolescents respond to depression much more than any other illnesses. Again, this was, these are the various studies which were done. Some were done in headache, a depression, 3 of them. Then there was an epilepsia partialis, and then again there was this study on spasticity. So the conclusion would be that rTMS is a promising treatment, but it has to, good profile of efficacy and safety has to be established before we start full-blown treatment of adolescent and children. Then there are rTMS studies. Well, the person who's quoted is sitting here. So this is the figure that I was talking about. You can see how many studies are being conducted now. Over the time, they have gone on increasing. So this is one figure which talks about how much we have been taken over by rTMS, and we are into it with a lot of fervor and lot of zest. So people who have rTMS should actively start researching in this field. And we have also taken it, and recently when we started, we now have 2 people doing work on this. So probably next couple of years, we might have BHU also coming with certain publications. So these are, now let's talk about innovation. First and foremost is innovation in coil, as was talked about. We have this coil, they have come over in so many years. There are certain benefits, but there are also limitations. So if we have a TH coil, well, this offers a good deep penetration and a strong magnetic field, which can penetrate deeper. But then there are limitations that it needs some more optimization, and it is a little complex. Then there is again UBC, that is precision is reduced, stimulation of the volume is not so much. Again, this is complex and needs further optimization, because we are still in the progress phase and we are focusing on it. So we have a lot of ifs and buts, yes and no, and we need a lot of operationalization and optimization for things to be really in a black and white shape. Then we have this HDC coil. This is safe and efficient, but it doesn't have a very good advantage over the classical figure of 8. Again, this again gives a good improved focality, but again the design is complex. Circular coil gives a consistent magnetic field, but needs a lot of comparative data. Again, multi-locus is faster in optimization and precise control. But then there are manufacturing challenges, because when we do an experiment, we should also know that a machine is built. The building a machine also is itself a complex procedure, which involves so many different things. Then we have AI everywhere, from DeepSeek to Grok, which is creating a lot of havoc. So this is an AI age, and AI is also used in rTMS. So how AI is used? There are so many algorithms which can be used to analyze the extensive data set. Supposing we do come up with a whole lot of experiment, we have so much of data to analyze that data itself. If AI is there, it becomes very easy, and it also becomes fast. So we have a conclusion at our hand in a immediate or in a very shorter span of time. This also can personalize therapy, and by using the AI and the data set, we can come up with a personalized data for an individual. So we can offer a recipe to an individual. So yes, Mr. X walks in, Mr. X has this is symptoms. So these are the investigations. We put it in the AI tells us, okay, fine, Mr. X should receive this amount of therapy by the rTMS. So the day will come when we will have AI at our hands, and we can offer treatment which can be personalized. Then research and collaboration can be helped. Predictive analysis, that this particular person gets this, so the prediction of chances of improvement, how much is it, that can be predicted with some amount of precision. Then this can improve the integration of rTMS with neuroimaging. Now we have this navigation and various methods where fMRI and MRI are incorporated, and rTMS, so that we come up with a better understanding. And then MRI scans can be optimized, and coil placements can be optimized and focused and given with a lot of precision. Again, this is another innovation where we have a wearable device of rTMS, like we have Holter. We put it in the pocket and move around and do our work, and the entire recording is there. So similarly, the individual can wear like a backpack, and then the rTMS is given like throughout the time, or it becomes very easy. The person doesn't need to come to the clinic. They can have this kind of a Holter monitoring kind of a portable device which can be worn for rTMS. Then again, there are innovations, there are limitations regarding the rTMS device. The innovation and the limitation. When improved power of circuit comes, there is an increased complexity, cost, and also some amount of heat generation. Then these integration can cause a lot of higher complexity, cause again maintenance, or becomes tricky. Open access TMS database can be incomplete, it can be outdated, and there can be potential biases. Efficient cooling, AI for operationalization and modular designs, again balancing innovation with a lot of practicality. We just cannot be very utopian in our like experience or in our outlook. We just cannot have the ideal setting, because nothing is ideal. So even a machine is not ideal. Machine comes with a lot of its limitations. So that has to be taken care of. And when we talk about data set enhancement, then implementation, it becomes complex, and there is always a need for standardization. Well, future direction, the market growth of rTMS is just boundless, and so it is a good market value for people who are manufacturing and people who are doing. So device has to be simplified, it has to be cool, and the costs have to be cut down to be accessible to others. Right now in AIIMS-BHU, we do not take any charges, but the day will come when we'll start charging. So that again, charges are not so accessible to people, especially people who are below the poverty line or who have this Ayushman Bharat, because this particular thing doesn't come in that gamut. The coil technology, again, new coil designs and ties with neuroimagings and brain-computer interfaces have to be real time. Then imaging and neurofeedback, incorporating the MRI, fMRI, and the real-time neurofeedback are other key points which can be effective in the future. Future directions, we can incorporate other methods along with the rTMS, like multimodal applications. rTMS with EG, rTMS with you name it and you have it, fMRI, FNIRS, combination with PET, DTI, then we can have improving precision, starting from genetics to the functioning of the machine, like rTMS brain network, neural oscillations, open loop and closed loop, precision with genetics, like we have this neurogenomics. You have this genetic makeup, come to the person, come to the desk, and you take medication as per your genetic requirements. So similarly, the day will come when we have rTMS explained on the basis of an individual's genetics, like we've talked about val homozygosity and all that. Precision with neuroimaging. So this is again a summary of innovations in rTMS, and this is from 2019 to 2024, and then their limitations. Neuronavigation for precise coil positioning, this is complex, needs training, because we recently had this particular person come to us for training us to locate the DLPFC. Although it may appear simple, but we really need to at least undergo the training once or twice. Then advanced software for precise stimulation, again standardization and reliability issues. Well, this is not to dishearten, it is to be in the real time. When we talk about some innovation, we should also be aware of the limitations of that innovation, so that we are attuned and adept to get over it. So we train ourselves, we optimize the machine, do something to get over those limitations. This is not puncturing the enthusiasm, but making it a real-time enthusiasm. User-friendly touch screen interfaces, cyber security is a huge concern. We live today in the times of cybersecurity and cyber fraud, tools for stimulating and simulating and visualizing target areas come with a lot of cost. The real-time adjustments again are complex, specialized. We have recently, there was one proposal where this was an old study by chanting Om. One of our colleagues is wanting to do that, but this was done, I think, in 2011 in Nimanth, that they had chanted Om and they had shown some amount of activity in the insula. And one of our thesis is actually was presented, but of course we have this neurology department where they are not ready for an fMRI, but let's see if we talk to them and we might come up with that. So AI driven real-time treatment adjustments, they increase complexity. Again, predictive analytics, data quality, bias risk, MRI accuracy and integration costs are all limitation factors. Well, to conclude, rTMS is here to stay, and this is very, very effective in depression and with various other modalities. So this is a concluding slide. These are the references. Thank you.
A very big thank you to Professor Mona Srivastav ma'am for such a great presentation, including the recent advances, especially in research, use of AI, and also the potential challenges involved. After this back-to-back 4 sessions of various presentation on different aspects of rTMS, now we will proceed to question answer session, where we will take questions from participants. In the beginning, we will take the questions which are already in the chat box. I would also request participants to, if they have further questions, please put in the chat box. And also we will give an opportunity to ask questions if somebody wants to ask directly. Were asked in the chat box. So we will start. The speakers will answer will tell the question and answer that simultaneously. Thank you.
Despite of multiple interruptions, I still see 24 participants online. So thank you so much for being with us, bearing the difficult situations. The first question was asked by a counseling psychologist. How can a counseling psychologist use this during the therapy, and where you refer to the psychiatrist? Now see, a counseling psychologist, particularly when they are evaluating patients, and it is always important to discuss about all the modalities of treatment whenever you are discussing a issue with a patient. The possibility of pharmacotherapy, possibility of psychotherapy, possibility of neuromodulation, all these options are available. If this option is available in your city or adjacent cities, definitely you can refer those patients to psychiatrist. Suppose as a counseling psychologist, if you see that despite of psychotherapy symptoms are not improving, they are persisting, then that require a different modality of treatment, then those cases can be referred to a psychiatrist. There are some defined indications like depression, OCD, cognitive symptom, negative symptoms of schizophrenia, which can be treated with rTMS with some success. So if there is a indication, definitely you can refer. I hope I was able to answer your question. If you have any other queries, you can put it in the chat box. Second question was, what are the advantages and disadvantages when compared with ECT? Actually, this question we got after the initial presentations. This question was partially addressed by Mona ma'am's presentation. Definitely, electroconvulsive therapy is superior to TMS if you are treating a psychotic depression, particularly, or catatonic symptoms, or severely suicidal patients. But TMS is recent protocols like SAINT protocol. It gives you can achieve remission early, and you can have a better remission than ECT. And if you are treating a non-psychotic depression, then TMS is equally efficacious like ECT. And regarding the side effects, electroconvulsive therapy is likely to have more cognitive side effects, whereas TMS is not having that type of side effects. Electroconvulsive therapy requires a specialized set of with anesthesia facility, whereas recovery room, all those things, whereas rTMS does not require all those things. Regarding the evidence of TMS and the cost, we have already discussed the evidences of rTMS in the series of presentations. You can refer to the Indian Psychiatry Society guideline and Lafayette's guideline recommendation for rTMS. Particularly, the level of evidence for depression is quite good. Level A and level B evidence. When it is coming to the negative symptom and cognitive symptoms of schizophrenia or auditory hallucination, the level of evidence is level C. So close to the open level studies and observational studies, retrospective chart reviews, all those evidences are there. Regarding the cost, particularly in the Western countries, the cost of therapy is a bit high, but particularly in the Indian setup, most of the setup they give government setup, they provide TMS in a very reasonable price, which is ranging from 100 to 200 rupees per session, Indian currency. So which is equivalent to around $2 to $3 US in per session. Whereas the private setup, they charge a bit higher price for the TMS sessions. The last question is how can a counseling psychologist, it is the same question of the initial question. If there is any more question, you can put it in the chat box. If you want to ask any question directly, you can unmute yourself and you can ask directly to any of the speakers.
I'll add one thing, if I'm audible. In the first question, when they have said when to refer to a psychiatrist. Now, I think that should be very, very important. There are so many red flags which should be identified, and an individual should be referred to a psychiatrist. Person not improving, person talking about suicide, person talking about self-harm, and other not responding, responding to medication, not responding to counseling sessions. And even in counseling sessions, the individual who develops transference, etc., all these people should be referred to a psychiatrist. I think because a psychiatrist will understand and identify those very minute details on what to do at which point in time. So I think it would be a prudent decision to refer to a psychiatrist or take a opinion rather than continuing with the individual who's just not responding or who is communicating so many other distress symptoms. So I think a session with a psychiatrist is imperative.
One question is there in the chat box. Any evidence supportive of effectiveness of rTMS as monotherapy in comparison to pharmacotherapy plus ECT or rTMS? Regarding the monotherapy, the number of evidences are quite less. And there is no, to the best of my knowledge, there is no study that compared the efficacy of monotherapy of rTMS with the combination of rTMS plus pharmacotherapy or combination of ECT with pharmacotherapy. So, but there are some network meta-analysis that gives evidence that rTMS in a particular given condition, particularly if you refer to an interesting article published in 2019 in British Medical Journal, regarding it's a systematic review on network meta-analysis of all neuromodulation strategies in the management of a major depressive episode. So that network meta-analysis basically compares the effectiveness of different neuromodulation techniques, and that article is freely available. You can refer to that article. It gives a clearly two things. One is what is more acceptable and what is more effective. In terms of effectiveness, bitemporal ECT is found to be superior among all the neuromodulation facilities in the treatment of depressive disorder. Bitemporal ECT, then right unilaterality, they are found to be superior. When it comes to TMS, TMS comes lower in the list, and the lowest is the pulsed TMS, that is having the lowest level of evidence. In terms of acceptability, TMS is more acceptable, and TDCS is even more acceptable than ECT. So
Can I double check again that other people are hearing and that we have a problem from the... Maybe I can ask the question. So how much is it, you activate the dorsolateral prefrontal cortex all the time in many of these schemes.
Yeah.
So one of the things is everything is very much focused on the locality, but how much is it, the electricity, there is no real biology of saying, I think the electricity in this brain area is dysfunctional. So what is the biology of saying, okay, you activate some neurons, but is there any evidence for a bad neurotransmission? So let's say it that way. So is there a reduction in glutaminergic neurotransmission in the prefrontal cortex? So if you do something, is it an epiphenomenon, what you do, or is it just the biology which you precisely affect with your different types of currents?
actually, it is the mechanism by which rTMS acts is the multimodal mechanism of action. Just close it. Yeah. There are evidences try to quantify, understand the biology of why there is an echo.
It has not been joined.
Yeah. So when rTMS is being given, people try to sorry for the now we connected with the internet. People try to quantify the biological changes that happen before giving rTMS and after giving rTMS. This is an accurate way to see what are the changes that are happening after giving rTMS. So particularly there are some region specific changes and there are some distal changes. You can say that proximal changes. Proximal change is what is the change that is happening at the site where you targeted the rTMS therapy. And distal change is the change that is happening in other brain areas where you have not targeted. Like in different psychiatric conditions, the biological changes are quite different. Particularly when we talk about depression, there is an article by Fox et al. In 2012. You can refer to that article. There is a functional connectivity between the anterior cingulate cortex and dorsolateral prefrontal cortex. And this functional connectivity is an anti-correlation. So what happens in depression, a lot of neuroimaging studies they did, and they used fluorodeoxyglucose to look for the regional metabolic activity. And they found that in patients with depression, particularly in the left hemisphere, the anterior cingulate cortex, subgenual anterior cingulate cortex activity is very high. And simultaneously, the dorsolateral prefrontal cortex metabolic activity is quite low. And they found that there is an anti-correlation and there is a functional connectivity. So when the anterior cingulate cortex activity becomes low, then the depressive symptom improves and the dorsolateral prefrontal cortical activity becomes normalized. That becomes normal. So these two areas are functionally connected. So there is a negative association between these two areas. Dorsolateral prefrontal cortex is hyperactive, then the anterocingulate cortex, subgenual anterocingulate cortex will be underactive, and vice versa. So because subgenual anterocingulate cortex cannot be targeted through the conventional rTMS, they suggested that if we can manipulate the dorsolateral prefrontal cortical activity by any way which is superficially located and easy for manipulation, then probably we'll be able to regulate the activity of subgenual anterocingulate cortex activity. So they have recommended high frequency rTMS, and they subsequently, through a series of neuroimaging studies, they found that the anterocingulate cortical activity is being modulated. So modulation of metabolic activity is one mechanism. Proximal metabolic activity and distal connected areas, they are being modulated. Second is neurotransmission. Third mechanism is neuroplasticity, formation of more number of synapses and more functional connectivity, either strengthening of a network or weakening of a network. You can strengthen a network by a stimulatory protocol. We can weaken a network by giving an inhibitory protocol. Then BDNF and other neurotropic related factor related activity. So these are multiple mechanisms which explains how rTMS works. Dr. Krishna, you want to ask any question? Okay. I hope I was able to answer your question, Professor Reiner. It is a series of activities that happen before and after intervention. Electrophysiological experiments, EEG studies, functional neuroimaging studies, all these support that after neuromodulation, there is a sequence of changes which is particularly responsible for the therapeutic effect. And these neurophysiological changes also act as predictors of response. The article that I have shown, and Dr. Mona ma'am has also shown that article, basically what are the electrophysiological and receptor related, epigenetic or receptor expression related factors which can predict the response to TMS.
Okay, yeah, thanks a lot. If there's no any other question there,
Yeah, there is a question in the Dropbox. How long do you effect of rTMS last in depression and OCD? Are there protocols for maintenance treatment, relapse prevention treatment? This is a very interesting question. Actually, if you give 10 to 20 sessions of rTMS in either in treatment of depression or OCD, the after effect usually lasts for 8 to 12 weeks. Mostly after 8 to 12 weeks, the therapeutic effect declines. There was a study, they did that study in patients with depression, and they compared the after effect of depression, after effect of TMS in depression in the first 4 weeks of follow-up and subsequent 4 weeks of follow-up. They found that the best response is in the first 4 weeks following the TMS in the follow-up period. As the time passes, the therapeutic effect gradually diminishes. That's why there is a reason many people require maintenance treatment for prevention of relapse. There is no clear-cut recommendation or guideline how frequently you should consider the maintenance TMS in the treatment of OCD, depression, or any other conditions. But whatever that maintenance protocols that are published, they recommend that slowly one can wean off the therapy sessions. One may consider 2 weeks, 2 sessions in a week for initial 4 to 6 weeks, and continuously monitor the symptoms. If the symptoms are not worsening, then one can think of spacing the sessions from 2 sessions in a week to 1 session in a week for another 4 to 6 weeks. If the symptoms does not worsen, then one may consider further spacing of 1 session every 2 weekly. This is how one can progress. This is what is done in previous published literature. This is how people has done it, and people used TMS maintenance therapy 6 months to 1 year for prevention of the relapses. So this is a very gray area which need to be further researched in the coming days. I hope I'm able to answer the question in the chat box. Any more questions?
Can I ask you, there's something which is coming up now is depression flow therapy. So where the electrical current is applied directly to the brain in low dosage. Are there any studies which compare these two conditions?
No, no, no. There is, to the best of my knowledge, there is no such comparison. Maybe the network analysis that I was referring to 2019 article. So they used epicranial stimulation as a modality of treatment for treatment of depression. And in that network meta-analysis, they compared epicranial stimulation with other neuromodulation techniques. And epicranial stimulation is somewhere around TMS, and the number of studies are quite less related to epicranial stimulation, where you need to do a interventional part, placing a pacemaker kind of thing on the epicranial surface, maybe in the over the dura, and continuously current will be delivered, and that will be stimulating a specific region of the brain. So then there is no head-to-head trial. Whatever the evidences are there, they are with reference to the network meta-analysis. I'm forgetting the name, but that article is published in 2019 in British Medical Journal, systematic review and network meta-analysis comparing the safety and efficacy of different neuromodulation techniques in management of major depressive disorder. This is the title of the article. We got another question in the chat box. Dr. Sasank Sinha has asked role of rTMS and aphasia and post-stroke dementia. There are some evidences, particularly use of rTMS in treatment of aphasia. You can target aphasia is usually evident if the patients with dominant hemisphere stroke is there. So what happens? Dominant hemisphere becomes dysfunctional, particularly the posterior part of the infrafrontal gyrus that becomes dysfunctional, which is actually attributing to aphasia. So you can do intervention in two ways. One way is once the stroke is stabilized, you can target the infrafrontal gyrus posterior part, that is F7. You can stimulate that, or after the stroke, there are some amount of cortical reorganization. What happens? The opposite homologous area of the Broca's area, that is in the right side, that interferes, that becomes hyperactive, and that interferes with the recovery of the primary speech area. So either you need to stimulate F7 by giving a high frequency rTMS or intermittent theta burst stimulation, or you need to inhibit the F6, that is the right infrafrontal gyrus, by giving a low frequency protocol of continuous theta burst stimulation, or low frequency rTMS that can be given. And regarding dementia, people has tried particularly dementia with Parkinson, dementia associated with Alzheimer's disease, dementia associated with vascular events, dementia associated with Parkinson disease. And the common target area is left dorsolateral prefrontal cortex. And 10 Hz and 20 Hz frequency rTMS has been tried. Evidences support that when you give a more intensive high frequency protocol, that gives a better result. More intensive protocol means instead of giving 10 Hz, if you are giving 15 Hz or 20 Hz protocol, targeting the left dorsolateral prefrontal cortex, that gives a better outcome, particularly in the context of dementia for cognitive improvement. There is another question by Professor Maheshwar Satpathy. What is the future of TMS in a resource-constrained society like India? If we have to integrate it to our clinical regimen, what sort of health policy strategies are required for promoting novel therapies? Thank you, Dr. Maheshwar Satpathy, for your question. It's a really interesting question and quite pertinent to trained settings like India. In India, rTMS is available in the government setting and in the private setting. If you go to the private setting, it is a costly affair, but it goes to a government setting. It is most of the centers, they offer rTMS free of cost or a very reasonable price. That is, the total cost of 10 sessions will be 2,000. 1,000 to 2,000, not more than that. So it is quite affordable. And recent Mental Health Care Act 2017 that has given insurance for the mental health conditions and mental health treatment. So it is covered under the Ayushman Bharat scheme and other insurance schemes. So people who are receiving rTMS for treatment, that is being that can be covered through the insurance schemes. And now majority of the medical colleges, they are coming up with rTMS facilities. So availability of rTMS may not be an issue in coming decade. So majority of the now the National Medical Commission of India has included rTMS is one of the required component in the PG departments of psychiatry. It's not a mandatory thing, but in the questionnaire they ask whether your department is having rTMS facility or not. So that's why majority of the institutes, they are procuring rTMS. So I hope in the coming decade, it will be easily available to Indian public for use. And even people from other countries, they are coming to India for having, particularly from the South Asian region, to have treatment. They are coming for recently in our center, a person from Nigeria, who is a student from studying in an Indian university, is receiving rTMS, which is not there in Nigeria and adjacent countries. So there is policies including, and the laws, they are including rTMS as a modality of treatment. Recently, the CDSCO has also included rTMS as a modality of approved modality of treatment. So suppose you are doing research on rTMS with a new protocol or a new target area or TDCS or a newer neuromodulation technique, you don't have to wait for CDSCO approval or DCGI approval. For DCGI approval is Drug Controller General of India, which is equivalent to FDA approval in USA. So it is already approved. They have given a blanket approval for some of the conditions. So it can be used for research. So there is, I see there is a bright future of TMS in the coming days.
Okay. Thank you. Thank you so much for the comprehensive explanation. It was really helpful. Thank you.
Thank you. Any more questions from the participants? If there is any further queries or you want to ask any question, you can write to the mail that has been forwarded from this website regarding the Zoom link. Your questions will be addressed and we'll provide you appropriate literature for that. Thank you so much. If there is no further questions, we'll close the session here. And Dr. Shruti has requested me to thank all the participants who joined from different parts of India and abroad. And special thanks to Professor Reiner Heun, who is the editor-in-chief of Global Psychiatry Archives and is the founder of Global Psychiatric Association. Thank you, Professor Heun, for your support and recording the session, making it available in the YouTube platform so that larger audience can refer to it. And we can have Professor Heun is the editor-in-chief of Global Psychiatric Archives, which is a journal for psychiatry and mental health related all related disciplines. If anybody is interested to submit their research work, they can submit to Global Psychiatry Archives. It's a very high quality review process and thorough process, and you can refer to the journal website. One good thing with the journal is all your articles after publication, the brief of those articles will be published in the YouTube channel. So anybody can listen to those summary of those articles. So Professor Heun, you want to say anything?
Yeah, I think it was my pleasure to support this, and I think it was a great meeting. And thanks for all the listeners, and thanks for the speakers. And we will put the whole of the meeting as well as individual talks onto the YouTube website, Global Psychiatry Archives, and you can reach them via our website, Global Psychiatric Association. And if you want to help, join, or contribute, you're very welcome. Okay, thanks a lot, and have a nice
you.
lunch in India, and we have breakfast in Glasgow. Okay, see you then, and I finish the recording now. Okay?
Thank you so much.
Okay.